Hello, my dear friends. I hope all of you are doing good. I'm Dr. Anuradha Dhawan here, your ophthalmology faculty. And in this session, we are going to do a revision of ophthalmology. Okay, so we had our classes, and I hope all of you did go through the workbook, because workbook contains a more comprehensive material for your preparation, which was based upon the classes which we had. And in today's session, we are going to revise the high yield topics which we need to know in ophthalmology. So it's a revision which helps you in going through the high yield topics, the topics which are important for your exam. Of course, it cannot replace your complete preparation, but the purpose is to revise all the important things. Okay, because these will be the things which you just cannot miss in your final preparation. But I'm going to stress, because I do get this question many times, that whether the revision PDF is sufficient. So dear friends, let me just tell you, revision means a revision. It builds. It's going to build. It's going to lay another layer to your preparation. Okay, it's going to put another layer to your preparation. Friends, do not replace it with a comprehensive learning through the workbook. These are the most important points. But workbook preparation, at least one reading of the workbook, I sincerely request you, where all the topics are there that you should do. Okay, a very good morning to all of you, and I really wanted to convey this to all of you, my dear friends, because I don't want that we are still at a stage, my dear friends, we are still at a stage where we have the time to build a nice foundation. Okay, the quick revisions you can do closer there. So please go through the workbook once. And most of you who have already gone, I'm very happy. We are going to revise all the important topics once again. Those who have not, besides the revision PDF and the video, please try to go through the workbook also. Yes, this is the revision PDF. This is the revision. But what I was kind of trying to stress is that revision means when you have done it once and now you are going to revise it. Okay, right? So a very warm welcome to today's session, dear friends. Let's revise all the high yield important topics for your ophthalmology. Okay. So I'll be going topic by topic, and then of course summarizing all the things in case which are not fitting in one topic heading. So let's start with the refraction data. Let's start with the refractive errors. Okay. Now in refractive errors, the revision which we are going to do is going to be based upon more clinical things. Okay, because exam is shifted towards more clinical things. So make an emphasis to learn the subject in a clinical way. Now, in refractive errors, what we need to know, we know that when the refraction is not occurring normally in the eye, a person suffers from refractive error. And when there is a refractive error, there is a vision problem. So why the refractive error occurs? Because in normal eye, according to the normal optics of the eye, yes, that's there, Nitesh. But concentrate on the PDF here, what I'm showing, because we are going to summarize there. Right. So refraction, the normal refraction, as all of you know, the light is going to undergo refraction at the corneal surface, which is the first interface where the light enters into the cornea, and the first refraction occurs. Then the second one occurs at the lens, and these two refractions, they help in focusing the light rays onto retina. Okay, so in normal optics, the light rays, they should focus at a single point on the retina. They should focus at a single point on retina. When this is happening, the eye is in a normal state of refraction. There is no refractive error, and the person is able to see clearly. Okay. Now, just to kind of give an average values, so do not get confused why I'm writing 45 here. In the workbook, 44 is written. Yes, the workbook, the revision PDF will be shared with you. I will be sharing that with you. Okay, guys? Right. So to have a fair idea, because it's difficult to remember so many values, so just in a simplified way, you can take the total refractive power of the eye as plus 60 diopter, majority of which is contributed by cornea, which is, you can mark it as 45 diopter, and the lens as 15. Okay, now most of the time we are not getting now these kind of numerical value questions, so do not bang your head, oh, it is 44, 45, 46. To have an idea, out of 60, 45 is by cornea, 15 is by lens. This is much easy to remember. So this is more or less to just let you know that cornea is the you can say most effective refractive surface, and then is your lens. Okay, now with that, okay, so all of you, you'll be getting the PDF. Now let's concentrate on what we are revising at the moment. Now, when the light rays are not going to get focused on the retina, then the vision will be blurred. So we will get a refractive error. Now have a look here, and all of you, you should be able to identify what kind of refractive error is shown in this image. So here, friends, the light rays are focusing in front of the retina. They are not getting focused on the retina. They are getting in front of the retina. And this happens when a person has a refractive error of myopia. So when it is a myopic refractive error, the light rays, they focus in front of retina, and the image which is formed is blurred. Whereas there can be a situation when the light rays are focusing behind retina. When the light rays are focusing behind retina, again, the image is going to be blurred, and this type of the refractive error is hypermetropia. Okay, so yaad aa gaya? When the light rays are getting focused in front of the retina, then the refractive error is myopia. So this can be imagined as the eye is showing more converging power than it should have. So that is why the light rays are focusing in front of retina. So I always say the easy way to remember is myopia means more converging power in the eye. Okay, guys, myopia means more converging power in the eye. Whereas in hypermetropia, there is less converging power in the eye. So the rays are focusing behind retina. So this is your myopic refractive error, hypermetropic refractive error. Now, these two things, they can come as an image-based question also, beta. They can show you the image of this refraction and they can ask you to identify. So very easy to identify. Then comes the correction, how you are going to correct a myopic refractive error. So again, with the concept, if you make a concept that myopia means more convergence, if the eye is having more convergence, you will do correction by providing a diverging lens to the eye. Okay, so more convergence is happening, so you will be correcting this refractive error by providing a diverging lens, which is your concave lens or a minus lens. So myopia is corrected by providing concave or also called as biconcave lens or also called as minus lens. Okay, myopia, minus lens, or concave lens. So that is how you will correct. So once you have provided this lens, so you can see the rays which were getting focused in front of retina, now they are getting focused on the retina and the person will be having now a clear vision. Okay. Whereas in hypermetropia, as I told you, the eye is having less conversion power. So here you will be providing a lens which is converging or which is a convex lens. So hypermetropia is corrected by providing convex lens or also called as a plus lens, because you need to add to the converging power of the eye. You need to add to means plus. So that's why you're giving a convex lens. Now this is also called as biconvex lens because both the surfaces anterior and posterior are convex. So again, the correction of refractive error can be a question in your exam, beta. Myopia is corrected by minus lens or concave lens. Hypermetropia is corrected by convex lens or plus lens. Okay, bache? Simple. Then this biconvex lens can be used. What are the other uses or what are the other conditions where you will use the convex lens? So not only for hypermetropia, so we will also be giving biconvex lens in the prescription for correction of, so all the uses I'm going to list here. So correction of hypermetropia, which I just told you. Then correction of presbyopia. Okay, because in presbyopia, there is weakness of the accommodation. In presbyopia, there is weakness of accommodation, which is again convergence. So that is why you are giving a plus lens. And at the same time, the correction of aphakia is also done using a plus lens. The correction of aphakia is also done using the convex lens because there again the eye is highly hypermetropic. So all these three are your uses of convex lens, bache. ठीक है, hypermetropia, presbyopia, aphakia, all are corrected by using a plus lens or biconvex lens. Okay, right? Then you should also know, we know the myopic and hypermetropic eyes are having certain characteristic features. Out of this, we'll be revising what are the changes which occur in the retina in pathological myopia. So what was pathological myopia, friends? Pathological myopia is when myopic refractive error is more than 6 diopter, that is more than minus 6 diopter, more than minus 6 diopter of myopia, along with chorioretinal degenerative changes. So that is called pathological myopia. So this is the definition of pathological myopia. When myopia is more than minus 6 diopter and there are various chorioretinal degenerative changes. And what are those chorioretinal degenerative changes? The presence of a temporal crescent around the optic disc, presence of posterior staphylloma. There can be a Foster-Fuchs spot, which is a hemorrhage on the macula, a small hemorrhage on fovea or macula. There can be Lecker cracks, which are breaks in the Brooks membrane. There can be a choroidal neovascular membrane developing, choroidal neovascular membrane developing. And there can be peripheral retinal degenerations occurring, out of which the most common is your lattice degeneration, which can result in the formation of some holes, and presence of rhegmatogenous retinal detachment, which is a risk factor. If there is a holes, then there can be occurrence of rhegmatogenous retinal detachment. So please do remember, these are the degenerative changes which can be seen in the fundus in a case of pathological myopia beta, right? Degenerative changes seen in the fundus in the case of pathological myopia. Temporal crescent, posterior staphyloма, a Foster-Fuchs spot can develop, lacquer cracks can develop, there can be formation of choroidal neovascular membrane, there can be degenerations in the peripheral retina. For example, lattice degeneration, there can be development of holes, and there can be development of rhegmatogenous retinal detachment. Okay, beta, right? Then coming to the third type of your refractive error, which is astigmatism. So in astigmatism, friends, the light rays are not focusing at a single point. In astigmatism, the light rays are not focusing at a single point because they are getting refracted differently at different meridians. Okay? And in regular astigmatism, we get two principal meridians, vertical and horizontal. In regular astigmatism, the cornea shows two principal meridians. One is vertical and one is horizontal. Now, based upon where the light is focusing in horizontal meridian and in vertical meridian, there can be different types of astigmatism. We can have 5 types of astigmatism, regular astigmatism. What I'm talking here is regular astigmatism. So these are the different types of regular astigmatism. And what is regular astigmatism? When you have two principal meridia, remember, one vertical and one horizontal. Now here, let's revise with the figures here, bache. What is a simple myopic type of astigmatism? In simple myopic astigmatism, at one meridian, the light rays are focusing on the retina, but at the second meridian, they are focusing in front of retina. So one meridian, no refractive error, other meridian, myopic refractive error, that is simple myopic beta. Okay. Then second type is simple hypermetropic, in which in one meridian, light rays are focusing on the retina, but in the other meridian, behind retina. So one meridian, no refractive error, other meridian, hypermetropic refractive error. That is simple hypermetropic astigmatism. Then the third type beta. Third type is in which in both meridia, the light rays are focusing in front of retina, but at different points. So both meridia are myopic. So that will become a compound myopic astigmatism. Okay, right? And then fourth one is beta, in which both meridia, the light rays are focusing behind the retina, but at a different point. So both meridia are hypermetropic, and it is called compound hypermetropic astigmatism. And the fifth is in which in one meridian, the light rays are focusing in front. That is, one meridian is myopic. The second meridian, it is focusing behind the retina. So second meridian is hypermetropic, and astigmatism is called mixed astigmatism. Right? So these are your 5 types of astigmatism, which you can see in a case of regular astigmatism: simple myopic, simple hypermetropic, compound myopic, compound hypermetropic, and mixed type of astigmatism. And how do we correct astigmatism? The correction is by cylindrical lenses, or what is also called as a toric lens. Okay, so correction is by a special type of lenses which act in a particular axis. They are called cylindrical or toric lenses. Okay, bacha, that's the correction of your astigmatism. Now, something about the pinhole. Pinhole is used when you are testing a visual acuity. You ask the patient to read on the Snellen chart. If the patient is not reading the Snellen chart or any distance vision chart, normally, when the vision is not normal, then it is tested again by asking the patient to look through a pinhole, a small opening. So we ask the patient to look through the pinhole. Now, in this pinhole, there is a small central opening. As you know, there is a small central opening. The diameter of this small opening is just 1 millimeter. So it allows only the central rays of the light to enter the eye. Now, pinhole helps us in identifying or differentiating whether the vision problem is due to refractive error or due to some organic problem in the eye, some central pathology in the eye. Okay, and how we can see that? If there is improvement in the vision when the patient reads by looking through the pinhole, if the visual acuity improves, it means the vision problem is due to refractive error. Whereas if the vision worsens while looking through the pinhole, it means the problem is due to some central pathology of the eye. Central pathology means the central area of the eye is having some kind of pathology. And what it can be maybe a central corneal opacity, which is causing the vision problem, or a scar. It can be a cataract, which is affecting the central part of the lens, or it can be a disease of the macula, the central part of the retina. So visual acuity will worsen in these cases when the person is looking through the pinhole. So again, this you should know what is the use of the pinhole. The use of the pinhole is to differentiate whether the vision problem is due to refractive error or it is due to some kind of disease in the eye, other kind of disease in the eye. If there is improvement in the visual acuity when patient reads through looking at the pinhole, then it is a refractive error. If there is a worsening of the visual acuity, then the reason can be some disease of the macula, it can be some central corneal opacity, or it can be the cataract, which is involving the central part of the lens, right? Now this here, they can ask you a question, even the image, they can show you the image of the pinhole. So what all images you are seeing today, beta, they can be asked in the exam. Okay, so I'm going through the images which can be asked in the exam. So all these images can be asked as image-based question. Now then, coming to a special condition which is called as aphakia, and when there is aphakia, that condition is corrected by different methods. One method is by providing the aphakic glasses. Now, what is aphakia basically? So as all of us we know by now, when there is absence of lens in the eye. So when there is neither a natural lens nor an implant in the eye, so that is a condition called aphakia. Now, aphakia is a condition in which eye becomes highly hypermetropic, because you remove the lens, the eye is now in a state of high plus refractive error. So in those cases, the one method of correction is by giving the patient aphakic glasses. So aphakic glasses are your high plus glasses in the range of +8 to +10 diopter. Now, as you can see, this gentleman is wearing nearly +10 diopter of glasses. So these high plus glasses are called as aphakic glasses. Now, these glasses, they are associated with a lot of side effects and discomfort to the patient, because we know the plus glasses, they will cause magnification. So there is a huge magnification image magnification when the patient is looking through these glasses. So that is one side effect. Now, when image is magnified, the field is narrowed. So that's the second side effect, that the patient is able to see, but the field of vision is very narrow, because everything is appearing magnified. Then there is a different sizes of the image, especially when patient is using unilateral aphakic glasses, that one eye high plus glass, other eye normal. Image formed by two eye, the size of the image will be different. The size of the images will be different. So one eye you are seeing a bigger image, other eye you are seeing a normal image. That's called anisotropia, right? And then because of these high plus glasses, the patient, due to spherical aberrations in these glasses, the patient gets again image distortion in the form of pincushion effect, and also a jack-in-the-box scotoma, in which the objects are sometimes in the field of vision and sometimes they are not in the field of vision. That's called jack-in-box scotoma. Okay? So aphakic glasses are not a very good option to correct aphakia because of all these side effects. So what is the option? The other options are, rather the better options are, for correction of aphakia, you can give contact lenses, because they produce less image magnification, and we can do secondary intraocular lens implant, that you did not do the implant in the first surgery, but you can do it now. So that's the better option. So this again can be asked as a question, that what is the best option for correction of aphakia? Your answers should be, friend, over the glasses, contact lenses are better. Okay, and the best option is by putting a secondary implant, because that will be giving the best image formation for the eye. Okay, right? Fine. Now coming to a very important aspect in this chapter, which is your how will you be correcting the refractive error. So we just went through different type of the refractive errors. Now the very important part of this chapter for your exam is, beta, how to correct the refractive error. Now in correction of refractive error, friends, the first step is in doing an objective measurement of the refractive error. So for that, you will be doing what is called as retinoscopy, which is objective measurement of the refractive error. Okay, so we will be doing retinoscopy. By retinoscopy, we will be checking that what is the refractive error in that eye. So once we know the refractive error in that eye, then we will be providing correction in the form of the glasses to that patient. Okay, beta? Now in retinoscopy, one should remember, as we discussed, especially for children, the measurement of the refractive error is also done by using cycloplegic drugs. So in certain circumstances, you will be using use of cycloplegic drugs will be done in retinoscopy, and this is especially done in children. Okay, this is especially done in children. Now, use of the cycloplegic drug, the drug of the choice in children, the drug of the choice in children in less than 5 years of the age is 1% atropine ointment. Okay, 1% atropine eye ointment. So please take this as a, this should be marked as an answer if there is a drug of choice for children. And irrespective of the age, when there is squint, again, atropine is the choice. Atropine is the choice. Okay. When there is squint, then you do not think of the age. Even in 7-year, 8-year-old child, you will be using atropine as the cycloplegic drug. If you remember, we have done the different cycloplegic drug, atropine, homatropine, cyclopentolate, which are your main drugs. But if you are doing refraction in a patient of squint, then atropine should be chosen as the refractive, the cycloplegic drug for refraction. In younger age group, we use the eye ointment. In older age group, we use the eye drops. Okay, bache? Right? Okay, so now you did the retinoscopy and now you get to know that what is the refractive error. Now, how we will be providing now glasses. So that is the second part of here, that how to convert a retinoscopy into glass prescription for the patient. So in that case, there are 3 steps. So one, you should note the, what is the, type of the lens in both meridia, or the correction in both meridia. Okay, whether it was plus, whether it was minus, you will note that. Then you will consider the working distance. You will be subtracting the reciprocal of the working distance, and you will also be making correction, subtracting the cycloplegic correction if it was used. Okay, so that is where you will convert retinoscopy into a glass prescription. So I have put this into a very simplified language so that what we are doing, you are getting to know. You will note what is the lens in both meridia, so that will be given to you. Then you will subtract the reciprocal of the working distance. Most of the time the working distance is 1 meter beta, so you will be subtracting 1 diopter from the lens which is there in that meridia, and then you will be correcting for the cycloplegia if that has been used. Now, to correct for cycloplegia, for atropine, you will do a correction of -1 diopter. You will subtract 1 diopter. For cyclopentolate, you will do -0.75 diopter. Okay, so these are the 2 commonly used drugs. Mostly in the question, you will be getting atropine. So for atropine, you will subtract -1 from the retinoscopy. If they say cyclopentolate, you will subtract -0.75. If there is no cycloplegia used, you will not subtract anything for cycloplegic drug, of course, when it is not used. Okay, now, let's do 1 or 2 examples here. So let's do an example how to get glass prescription from the retinoscopy. So supposedly the retinoscopy finding is that the retinoscopy is being done at a working distance of 1 meter and under atropine. Okay, so example is it is done at working distance of 1 meter and under atropine. And what is the retinoscopy finding? The retinoscopy finding is +3 diopter in this meridian, vertical meridian, and +4 diopter in horizontal meridian. So as I told you, you noted what is there in 1 meridian, what is there in 2nd meridian, +3, +4. Then the second step is to subtract reciprocal of working distance. So working distance is 1 meter. So you will be subtracting -1 here and -1 here. Okay, beta. Then for atropine, you have to subtract another -1 diopter. So you'll be subtracting -1 for atropine here, -1 for atropine here. So what is now the corrected cross here? The corrected cross here is +1 and +2. Okay, so after correcting, the cross is now +1 and +2. So it means there are 2 different type of the corrections in vertical meridian and in horizontal meridian. In this, the smaller one will be given as a sphere. The smaller one will be given as a sphere. So how I will be doing now? I will choose the smaller one as the spherical power. So +1 diopter sphere I will be giving. Now sphere is acting all around. So what is residual left after +1 sphere? Residual left here is +1. So +1 will be given as a cylinder. This cylinder is needed at 180 meridian. It is needed at 180 meridian. So in glasses, that will be placed at 90-degree meridian. In glasses, that will be placed in 90-degree meridian. Okay. Again, after the class also, I had got a lot of questions about the axis of the cylinder beta. Listen to me carefully. you will check in which meridian the cylindrical power is needed. For example, in this case, cylindrical power is needed at 180-degree meridian, horizontal meridian. So it will be provided in the glass prescription, you will provide it at 90 degree. Okay? If it is needed at 90 degree, you will provide it at 180 degree. So that is how the cylinder is placed in the glasses. Okay, beta? So please go through this one with me once more. Here, the examiner gives you that retinoscopy is done at a working distance of 1 meter under atropine, and +3 and +4 are the values which they got. So in this case, we will subtract -1 for the working distance. We will subtract -1 for the atropine. Okay. After doing this correction, this is the cross which we will get, that now it is +1 and +2. In this case, +1, which is a smaller power, will be used as a sphere. The smaller power will be used as the sphere. So what is remaining required at 180 degree? Another +1 diopter. So that will be given as cylinder. And this cylinder will be given at 90 degree. The cylinder will be given at 90 degree. ठीक है बेटा, इसमें बिल्कुल कुछ कंफ्यूज नहीं होना, स्टेप बाय स्टेप जाओ, you will never be wrong. Go step by step. Okay? So let me take you with another example. So in this case, the retinoscopy is done. Retinoscopy is done at 2/3 meter working distance. Okay, and no cycloplegia. No cycloplegia. Now, if the working distance is 2/3, if 2/3 is the working distance, the correction which you will do, or the subtraction which you will do, will be 3/2. That is -1.5 diopter. I'm just telling you this for example. Most of the time it will be easy, just 1 meter. But if they say 2/3 meter working distance, so the correction which you will do will be -1.5 diopter. And what is the retinoscopy? The retinoscopy is -2, -2. Okay, no cycloplegia, so no correction needed for that. So correction which we will be using will be only -1.5, -1.5. Right? Yes, sir, Dr. Venkateshan, as I told you. So here the corrected cross will be -3.5, -3.5 beta. ठीक है, corrected cross क्या हो गया? -3.5, -3.5. Now both the x's, the same thing is there, so it will be only -3.5 diopter sphere in this case. Only -3.5 diopter sphere in this case. No cylinder, because there is no residual power then, isn't it? Right? ठीक है बेटा, right? And just one last example of another of the cylindrical one. So supposedly the retinoscopy, just the third one here, the retinoscopy is -3 and -1. Again, no cycloplegia, the working distance of 1 meter. -3, -1, no cycloplegia, working distance of 1 meter. Okay, so after correction, what will be there? -1, -1. Okay, after correction it will be -4, -2. ठीक है बेटा, अब इसमें what will be the spherical correction? What will be the spherical correction here? -2 will be given as the sphere. ठीक है ना? -2 will be given as the sphere. So what is remaining here? -2 is being given as the sphere. So what is remaining here? Another -2. So that will be required as the cylinder. That will be required as the cylinder. Now this is required at 90 degree. So where will you place that? You will place that in the glasses at 180 degree. ठीक है बेटा? -2 will be used as sphere. The remaining -2 will be used as cylinder. It is required at 90 degree. So it will be placed in the glasses at 180 degree. So this will be the glass prescription for this retinoscopy. ठीक है बेटा? Right? Fine. So these are the various examples. So if you keep the fundamental concept in mind, you will never be wrong. So what is the concept? First of all, check what is the correction or retinoscopy given for both the meridia. What is the working distance? For working distance, you have to subtract reciprocal of the working distance. Check for cycloplegia, whether it is there or not. If it is there, you have to subtract -1 for atropine. Come to your corrected cross. In that, take smaller power as the sphere. Okay, remaining power as the cylinder. And the axis of the cylinder is 90 degree to where it is required. That's what I'm telling Dr. Rahman. How to know where the cylinder is required? See where the residual power is there needed. For example, in this case, the residual power is needed at 90 degree. So the cylinder will be placed at 180. If the extra cylindrical power is needed at 90, it will be placed at 180 in the glasses. Okay, right? Okay. Fine, beta. So that is the glass prescription. So I hope all of you are fine now about the cylinder. So if the extra power of the cylinder is needed at 90 in your cross, it will be placed at 180. If it is needed at 180, if it is needed at 180, it will be placed at 90. That's it. Okay, right? Take it. Going forward. So that was about the glasses. So in that kind of thing, they can ask you to convert the retinoscopy into a glass prescription, and they can also ask you to identify the refractive error. So can you identify this refractive error, beta? What will be the name of this refractive error? In this, there is hypermetropia, right? Both hexes hypermetropia is there. So this will be a compound hypermetropic astigmatism, beta. Okay, so if I have to name this refractive error, because at both hexes there is hypermetropia, so it will be compound hypermetropic astigmatism. Okay, beta. If you have to name this refractive error, what will be the type of the refractive error? Both the x's myopia is there, so this will be compound myopic astigmatism. Compound myopic astigmatism. Okay, that will be the name of the type of the refractive error. Whereas in this one, where the same refractive error is there in both the meridia, so this will be simple myopia, no astigmatism, simple myopia, right? So that is like if something like that is asked, so even you can answer that also. Okay, guys, right? Perfect. Okay, but after glasses, let's revise something about the contact lenses. Now, contact lenses are the second option to correct a refractive error, and they are preferred over the glasses. So what will be the indications, or what are the situations where you will be preferring the contact lenses? That will be for cosmetic indication, that for cosmetic reasons, if somebody doesn't want to use the glasses, they can use contact lenses. Then they are better for anisometropia, that when there is difference between the refractive error in two eyes, significant difference, then it's better to use contact lenses, because there will be less anisokemia. If there is too much of difference between the refractive error of two eyes, the size of the image of the two eyes will be very different. So in those cases, contact lenses are better option. Then contact lenses are also better option for irregular astigmatism. When the patient is having irregular astigmatism, when there is different refractive error at different axes, there are no two principal meridia, there are different axes in the eye, cornea. That is called irregular astigmatism. In those cases, contact lenses are better option. So this can happen, for example, when there is corneal scarring, or in the cases of keratoconus. So these are the cases then the eye will show irregular astigmatism. So in those cases, contact lenses are your better option. And I just told you, even for aphakia, the contact lenses will be better option over the glasses or spectacles in the case of aphakia. So these are the few indications where you will prefer contact lenses over the spectacles. And what are the disadvantages of the contact lenses? What are the disadvantages of the contact lenses? There are two main disadvantages, beta, which you should know. One is they can cause an allergic type of conjunctivitis, which is called giant papillary conjunctivitis. They can cause giant papillary conjunctivitis. Okay, we are going to learn about that shortly. The second is they can be a risk factor. They can be a risk factor for corneal ulcer. And what is the commonest? What is the commonest infection which can occur in these cases? Commonest is Pseudomonas. Pseudomonas ulcer is common in contact lens user. And then second is acanthamoeba keratitis. Right? So these are the two disadvantages with the contact lenses. The giant papillary conjunctivitis, and then they can also be risk factor for corneal ulcer, out of which commonest is Pseudomonas. The second is acanthamoeba. Okay, right? Fine. Then besides this, besides spectacles, besides glasses, we have refractive surgeries to correct the glasses. In refractive surgeries, beta, you should know especially the main procedures. The first one is your LASIK, which is laser assisted in situ keratomiliosis. The second is RELAX or SMILE, which is small incision lenticular extraction, that a part of the cornea is removed. The third one is phakic intraocular lens, or what is also called as ICL, which is an implantable columnar lens. that you implant another lens in the eye. Okay. Now LASIK, in LASIK and Relax Smile, we can correct up to minus 12 diopter of the refractive error, myopia. Okay. And in phakic IOL, we can correct even beyond that, right? Now, especially for LASIK eye surgery, you should know at least the basic. The basic is that in LASIK, we make a flap of the cornea. As you see here, we make a flap of the cornea, and at the base of the cornea, at the base here, the laser is applied. And the laser which is used is your excimer laser. Excimer laser is applied. This laser ablates the cornea. Ablation ka kya matlab hai? It removes a part of the cornea. So that changes the corneal curvature. For myopia, central part is flattened and it corrects the corneal myopia because it flattens the corneal curvature. So that is the basic principle of LASIK. So that you should know that in LASIK, a flap is made, then excimer laser is applied, and that laser causes flattening of the corneal curvature. Okay? Then for LASIK, you should know that what are the contraindications. The contraindications for LASIK. It is not that for all or everyone you will do this procedure. What are the contraindications? Number one, the age less than 21 years. Okay. Unstable refractive error. If the refractive error is not stable, you should wait. Then thin cornea. When the corneal thickness is less than 450 micron. And then in keratoconus, you will never do LASIK. Okay, so these are the few important contraindications of LASIK which you should know. Okay, keratoconus, thin cornea, unstable refractive error, and age less than 21 years of age. Because these kind of questions, they can come up where they tell you a case scenario that whether you would go for LASIK or not. You will not be going for LASIK if these contraindications are present. Okay, beta, right? So these are the few points, important points, which we have revised for refractive error. And now let's move on to the simpler topic, which is conjunctiva. And as I told you, this last exam, we did not get a question directly from conjunctiva, I suppose, but don't skip this topic because it's too easy and too easy to remember the different conjunctival conditions. There is no kind of complicated things over there. So if a question comes, you are sure to answer that correctly. Okay, bache, right? So the conditions which we are going to revise for different conjunctival diseases, the first one is your trachoma, bache. Trachoma. So trachoma is a type of conjunctivitis or the infection of the conjunctiva, which is caused by the organism is Chlamydia trachomatis. Which serotypes of Chlamydia trachomatis that you should know? Serotype A, B, BA, and C. So these are the serotypes which cause trachoma. The other serotypes of Chlamydia trachomatis, the D to K, they cause different kind of conjunctivitis, which is called as adult inclusion conjunctivitis. Because trachoma is a chronic conjunctivitis of children. So that starts from children and then if it spreads to the community, but it's more common in children. Serotype D to K, they cause adult inclusion conjunctivitis, which is also given the name swimming pool conjunctivitis because it tends to spread when the people are using a public swimming pool. Another virus which can cause swimming pool conjunctivitis is your adenovirus. Okay, so these are the two organisms which can cause swimming pool conjunctivitis. One is your Chlamydia trachomatis, serotype D to K. The second one is your adenovirus. So this was a kind of a related information, so that has been put here. Now coming back to trachoma, beta. Trachoma, as I told you, is a chronic conjunctivitis. Chronic conjunctivitis caused by trachomatis A, B, BA, and C. There are typical signs which you see in a case of trachoma, which you should know. And what are these signs? The different signs of trachoma you should know, beta. One is the presence of sago grain follicles in the upper tarsal conjunctiva. Okay, so have a look here. Large sized follicles, they appear on the upper palpebral or tarsal conjunctiva, which are called as sago grain follicles. Then these follicles, they can also develop on the limbus. Then they are called Herbert follicles. When Herbert follicles, they heal, they leave Herbert pit. So what you are seeing here is once the follicles, they have healed, they leave these pits. They are Herbert pits. And then you will see the scarring in the conjunctiva, which is called Art's line. Art's line. So these are typical signs which we see in trachoma, beta. Okay. So coming back, which you should know, they are presence of sago grain follicles, presence of Herbert follicles, which are seen on the limbus. When Herbert follicles, they heal, they can leave Herbert pits. And then presence of a scarring in or subtarsal fibrosis, what we call as, that is the presence of Art's line. All these are the features which you see in trachoma. Okay. Now in trachoma, because this condition can become endemic, so there are methods to control that, and WHO has given a specific strategy, which is a very favorite question with the examiners. This strategy advised by WHO is known as SAFE strategy. SAFE strategy. Okay, the SAFE strategy is for trachoma, and what are the different components of this strategy? Here, the S is for the surgery, for example, for the correction of tracheasis, which can again occur as a complication of trachoma. A is use of antibiotics, and antibiotics which are used here is azithromycin. F is facial cleanliness, because flies are vector for trachoma. So poor facial hygiene will lead to spread of the disease from one person to another through flies. E is for environmental improvement, again to reduce the transmission of the disease. Okay, so this is a very, very important and very easy to remember thing. All the components of the SAFE strategy you should know better. S for surgery. Surgery mainly is done for tracheasis. A, use for antibiotics. The antibiotics which are preferred are azithromycin. F for facial cleanliness, and E for environmental improvement. And this strategy is for control of trachoma as or eliminate it as in the endemic areas where it can be a public health problem. Okay, so this is what you should remember about trachoma, SAFE strategy, and the specific signs beta. Okay, beta. Then moving to another infective conjunctivitis, which is your ophthalmia neonatorum. Ophthalmia neonatorum is the conjunctivitis which you see in a neonate, that is within 28 days of the birth. So this can be asked as a clinical case question also. This can be asked as a clinical case or image question. They can show you this image as you see here, that there is discharge, there is matting of lashes in a neonate. If this is there, it means it's a conjunctivitis ophthalmia neonatorum. Okay. What can be the different causative agents of the ophthalmia neonatorum? It can be chemical in nature. If it is chemical in nature, it is due to the use of silver nitrate solution, which causes a kind of allergy and conjunctivitis. So this will be developing very early because silver nitrate was initially used as a prophylactic agent in neonates. So chemical ophthalmia neonatorum will be developing very early, within hours, as soon as you administer the solution. Then gonococcal infection, which is transmitted from mother to the neonate, that can occur. The onset of this kind of ophthalmia neonatorum is usually within 1 to 4 days of the birth. And gonococcal is most dangerous. Remember, gonococcal is most dangerous because it can lead to corneal ulcer. The gonococcal conjunctivitis can lead to corneal ulcer. So that's most dangerous. Then chlamydia, again from the maternal genital tract, it can, during the delivery, it can pass on to the neonate. The onset of infection in these cases is usually between 5 to 14 days of the birth. This is most common because chlamydia infection in genital tract is very common. So that's the most common one. Besides this, the staph aureus and herpes simplex, they can also be the causative agent. Staph aureus tends to occur after 1 week of the birth, and herpes simplex usually later after 1 to 2 weeks of the birth. So you should know the different causative agents for ophthalmia neonatorum. Gonococcal is most dangerous. Chlamydia is most common. Okay, and what is the prophylaxis? What is the prophylaxis for the ophthalmia neonatorum now? It is povidone iodine beta. It is povidone iodine. I know it will be difficult to memorize the duration. There has been a question in the past, but at least we can remember this, that chemical is within few hours. Gonococcal within a week, you can say. Okay. And if it is staph or herpes, it is usually after a week. Chlamydia, staph, herpes will be later. So gonococcal also tends to occur early. So at least try to remember it in that way. If we cannot remember the exact days, I know it's difficult. Okay. So gonococcal within first week and rest usually after 1 week. Right? Okay. So prophylaxis is by the use of povidone iodine. Then something I would like to, just 2 points which we should know, that how COVID-19 can affect the conjunctiva. Okay, so COVID-19, because still we get COVID-19 cases, so that can be a question in the exam. So if a person gets COVID-19 infection, the most common ocular symptom is in the form of conjunctivitis. Okay, a patient gets a red eye, and the conjunctivitis which occurs with the COVID-19 is a follicular type of conjunctivitis because it's a virus. So viruses, they cause follicular conjunctivitis. So in COVID-19, the type of the conjunctivitis which we get is beta follic. Okay? So the question can be what is the most common involvement in the eye in a person of COVID-19? So that is your conjunctivitis, and the type of conjunctivitis which is seen is the follicular one. Okay, beta? 2 things to remember. That's all they can ask. Then coming to another condition which can involve conjunctiva, which is an allergic condition, is your vernal keratoconjunctivitis. Vernal keratoconjunctivitis or VKC. The other name of this condition is spring cutter. Okay, right? So this can be asked as a clinical case question as well as an image question, beta. Okay, so they can give you an image or ask without an image. So how the question will be there? The question will be there that a young boy will present with the symptoms of itching, ropey discharge, redness of the eye, which is worse in summer. Okay, so the clinical case scenario of a young boy presenting with itching, ropey discharge, worse in summer, and this kind of the sign seen on the lid. So what you are seeing on the lid is giant papillae. What you are seeing on the lid here is giant papillae. Just a second here. Right? So what you're seeing here, bache, is your giant papillae. This is a case scenario of vernal keratoconjunctivitis. And these giant papillae, they are giving a typical appearance to the conjunctiva, which is called as cobblestone appearance. Okay, so remember this clinical case profile: a young boy with itching, symptoms of redness, watering, ropey discharge, which is worse in summer. So coming here, itching with ropey discharge, the papillae which are giving the cobblestone appearance there. Now, when these papillae are present on the limbus, then they are called as Horner-Tranta spot. Horner-Tranta spot. Okay, and there can be a complication in the form of an ulcer on the cornea, which is called shield ulcer. Shield ulcer that can develop in a patient of VKC. And another sign which we see in a patient of VKC is what is called as pseudogerontexon or a cupid bow, which is nothing but a peripheral arc-like opacity, in the peripheral cornea. Okay, now these are the signs. It's an allergic conjunctivitis in which there is a type 1 hypersensitivity due to some dust or pollen or an external allergen. Yeah, the papillae, they have a flat top. Okay, as you see here, the papillae, they will always be having a central red area and a flat top. They will be raised but flat topped. Okay, right? So remember, simple features of VKC, the age profile and the typical signs which you see here: cobblestone pop papillae, Horner-Tranta spot, shield ulcer. There can be presence of cupid bow or what's called as pseudogerontexon. Okay, right. Now, a similar kind of the clinical picture can also be seen in the condition called giant papillary conjunctivitis. That is, again, you are seeing giant papillae with cobblestone appearance, but here it is due to, as I just told you, contact lenses. Here, this conjunctivitis is secondary mostly to contact lens use. So again, this can be a clinical case or image-based question, but here the profile will be a young adolescent or young adult mostly. Okay, there will be history of contact lens use, and of course there can be itching, there will be redness, there can be ropey discharge, the similar kind of symptoms, but no relation to the season, because it will be having no relation to summer season, because it is related to contact lens use. So when this is a clinical case profile, then you can mark the diagnosis as giant papillary conjunctivitis. A young adult or adolescent, history of contact lens use, symptoms of allergy, redness, papillae seen on the conjunctiva, the diagnosis is giant papillary conjunctivitis. Okay, beta? Right? Then in conjunctiva, please also remember about phyllectanular conjunctivitis. Now, this is again a hypersensitivity reaction, but here it is type 4 immune complex reaction, which is secondary to tubercular antigen or staph antigen. So a person who is having tuberculosis, suffering from tuberculosis or staph infection, can show up type 4 hypersensitivity reaction in the conjunctiva or at the limbus, actually, in the form of formation of phyllectin. These are your phyllectins. What are the phyllectins? These are nodular inflammation. So yellowish nodules at the limbus. You will see these yellowish nodules at the limbus. They are called phyllectin. So this is phyllectanular conjunctivitis. When there is formation of yellowish nodules at the limbus, that's called phyllectanular conjunctivitis. Okay, and it is secondary to type 4 hypersensitivity reaction to tuberculosis, because tuberculosis is endemic in India, so very commonly seen in Indian patients, or it can be due to staph antigen also. Okay, rarely this can involve cornea in the form of an ulceration, and that complication or that ulcer is called as fascicular ulcer, just the name it. If there is a complication by the corneal ulceration, just the name it. If there is a complication by the corneal ulceration, that ulcer is called fascicular ulcer. Okay, right? So again, in phallic-tanular conjunctivitis, you should know what the condition is, and you should be able to identify, if they show you the image, the yellowish nodule just at the limbus, at the junction of cornea and sclera. Okay, beta, right? Okay, bacho. Then coming to a condition which is called as xerophthalmia. Yes, keep remembering that, beta. And the sacrifice in your case is sacrificing your time, sacrificing your sleep, sacrificing away or give up. So don't do that. Just keep persisting, beta. Just keep persisting. Unless you, there is no substitute for hard work, bache. Absolutely. So whatever we say, whatever we do, we have to put in our best. We have to put in the time. We have to put everything what we have if we want to achieve the success. Okay. So that's why in the beginning only I told that if you think that only doing the revision of the few things will help, so that's not going to be the case. You must try to give a thorough reading to all your subjects and then revise, then revise. Okay, right? Okay, so this is xerophthalmia. Xerophthalmia means all the signs and symptoms which you see in the eye due to deficiency of a vitamin. Which vitamin? Vitamin A. Okay, so xerophthalmia is the set of the signs and symptoms which you see in the eye due to vitamin A deficiency. Beta. Due to vitamin A deficiency. Oops, I was going to highlight that, not erase. So vitamin A deficiency leads to xerophthalmia. Now this chart is very, very important because you should know what are the signs and what are the symptoms which can occur. And again, a very important question for your exam, beta. Very simple and very important question. So if a person, especially because children are more prone, especially the people who are malnourished are more prone, obviously, for the vitamin deficiencies. So the first symptom which will occur when a person starts having vitamin deficiency is night blindness. Okay, so this will be the first symptom reported by the patient. The first sign will be noted is the dryness of the conjunctiva, which is called as conjunctival xerosis. Conjunctival xerosis, or the dryness, extreme dryness of the conjunctiva. This will be followed up by formation of a bitted spot on the conjunctival surface. I'll just show you the image also. Then there will be stage of corneal xerosis. Xerosis, again, extreme dryness of the cornea. Next is the stage of corneal ulceration. Now, corneal ulceration can initially be involving less than 1/3 of the cornea, which is the stage X3A. But when it involves more than 1/3 of the cornea, then it becomes stage X3B. The corneal ulceration is also called as keratomalacia. The corneal ulceration is also called as keratomalacia. Okay? So ulceration, when it heals, that will be leaving a corneal scar. And you also see the changes in the fundus, which are in the form of pigmentary changes on the retina. Pigmentary changes on the retina, which is called as xerophthalmic fundus. Okay, so this happens sequentially, beta. First will be conjunctival xerosis, then bited spot, then corneal xerosis, then if it complicates, ulceration or keratomalacia, then sequelae or a complication of corneal scar, and if the changes they occur in retina, they will be in the form of the pigmentary changes. Now, questions can come up in different way. They can ask you, corneal xerosis is due to deficiency of which vitamin? That is vitamin A. Conjunctival xerosis can occur, or keratomalacia can occur, or bitted spot can occur due to deficiency of which vitamin? Vitamin A is one what we are talking about. Okay, and then they can also show you this image, which is showing you a whitish foamy, as if some foam is placed there. So a white foamy spot, which is usually on the temporal side of the bulbar conjunctiva. That is your bitted spot or bited spot. Okay, so this you should be able to identify. A white foamy spot on the temporal side of the conjunctiva or bulbar conjunctiva is bited spot, which is again seen in vitamin A deficiency. Okay, so even you can notice not only the spot, the conjunctiva is appearing dry also. So first will be conjunctival xerosis. The second will be the appearance of the bited spot. Okay, beta, right? So please do remember all the signs as well as symptom of night blindness which you see in patient of xerophthalmia, which is due to vitamin A deficiency. Okay, so coming to another conjunctival condition, which is very commonly asked, that is this can be asked as a direct image-based question. Question, identify the lesion, or there can be a clinical case scenario where they ask you that a person has noticed a fleshy growth in the eye, which is now covering the cornea, and this is the image. So I think all of you can identify this is a case of, or this is the image of pterygium. Okay, so a fleshy, usually kind of a triangular or wing-like growth from the conjunctiva encroaching onto the cornea, that is your pterygium. That is your pterygium. Okay, so you see here No problem should be there in the diagnosis here. This is your pterygium. Okay, beta, right? Then what you should know about pterygium, that what kind of changes are occurring. It's a not only degenerative, there is also hyperplasia. So it's given the name elastotic degeneration. The growth occurs because of the elastotic degeneration in the conjunctival tissue. Ultraviolet rays are considered to be exposure to excessive ultraviolet rays for longer durations, to dust, etc., is considered to be the risk factor for pterygium. Okay, then you should know that pterygium is considered to be divided into three parts. The advancing edge of the pterygium is called the head of the pterygium. The part which is at limbus is called as the neck of the pterygium, and this part which is towards the conjunctiva is called body of the pterygium. Okay, and in some patients this advancing edge can have a deposition of the iron. This can show a deposit or iron deposit in the cornea, and that iron deposit is given the name as Stocker's line. Stocker's line, beta. Okay, this is called as Stocker's line. So that should, again, you should remember what is Stocker's line. The iron deposit in the cornea in front of the head of the pterygium. Okay, right. So what should be the treatment of the pterygium is your question, beta. Of course, the treatment of the pterygium will depend upon how advanced or severe the pterygium is. Okay? If it is small, then it can be just observed, or if it is bothering the patient in terms of cosmetic reason, or due to double vision, or due to the decrease in vision when it encroaches upon the pupillary area, then excision is the treatment. Okay, you have to remove it. Excision is the treatment. But then recurrence is very common. Recurrence after the surgery is very common. So there are different methods which are used to prevent and treat the recurrence, which includes use of mitomycin C. MMC is mitomycin C. Use of conjunctival autograft or use of amniotic membrane graft. Okay, so all these they can be used. So in this case, the best. Okay, so that is beta usually the question which is asked, that what is the best treatment? If you have to choose the best treatment, please mark the answer as excision with conjunctival autograft. Okay, so all these methods which I have listed, they are of course used, but the best is excision with conjunctival autograft, which you should be your answer. Okay, do not get confused between different choices, different answers written at different places. The best treatment is excision with conjunctival autograft. Simple. Okay, right? Fine, beta. So these were the conditions in conjunctiva which you should know. Pterygium, you should know about vitamin A deficiency, the different types of conjunctivitis, especially follicular, giant papillary, which we discussed, VKC. Then in infective, you must know about trachoma and ophthalmia neonatorum. Okay, right? Okay, so we are now moving on to the cornea. We are now moving on to the topic of the cornea. And in cornea, just a quick recap of the different layers of the cornea. Okay? The different layers of the cornea we should know. We know the most top one is your epithelium. Then comes your Bowman's layer. Okay. Then the largest in thickness is your stroma. Then comes your Dua's layer. Then descemet membrane, and then endothelium of the cornea. Okay. So cornea is a multi-layered structure. Now, there are some peculiar features of these different layers which you should know. And what are those, beta? The layer which has been discovered latest. Okay, that is your Dua's layer, though it has been a time now, but it's the latest discovered layer. Then endothelium is very important because it is not only your most metabolically active layer, but it is also maximally responsible for corneal hydration. Okay, the endothelium is maximally responsible for your corneal hydration because it contains a sodium potassium ATPase pump, which keeps the cornea in dehydrated condition. Because if there is fluid in the cornea will become opaque. It will lose its transparency. So endothelium is the one which is mainly responsible for the hydration of the cornea. Then you should remember that Bowman membrane cannot regenerate. However, descemet membrane can regenerate. Okay. And if they ask about what is the toughest layer of the cornea, that is considered to be Dua's layer. Toughest layer of the cornea is considered to be Dua's layer. Descemet membrane can regenerate, and it is the most elastic layer. So again, it is a tough elastic membrane, but Dua's layer is the toughest layer. Okay, so these are the few things which you should remember about the different features of the corneal layers. Then a bit more. The endothelial cells, they have a very uniform shape, which is called as hexagonal shape. They have got hexagonal shape and they are arranged in a single layer. Okay. Then normal endothelial cell count in an adult. So this range you can actually write from not only 3000 but 2500 to even 3500 cells per millimeter square. They're more when we are born. As we age, it keeps on reducing. Okay, but the more important thing to remember is that if the endothelial cell count falls below 500 cells per millimeter square, the cornea undergoes permanent decompensation. Okay, so endothelial cells should be at some minimal level. Once the count falls below 500 cells per millimeter square, the cornea it will absorb fluid and it becomes opaque, and that's called as permanent corneal decompensation. Okay, beta? So endothelial cell layers is very, very important for maintaining the corneal transparency. Okay. Then we should also know the different investigations which we do. What is the purpose of those investigations? To know certain important parameters of cornea. So first one is your pachymetry. What is pachymetry, beta? Pachymetry is the technique or the method or the test used to measure corneal thickness. Then keratometry. Keratometry is measurement of central corneal curvature. Central corneal curvature. Then we have corneal tomography, in which we are doing. Beta, you already remember palisades of Vogue, Dr. Chauhan? है ना, तभी तो याद आया आपको. Of course, palisades of Vogue are the stem cells which are present at limbus. Okay, right? So corneal tomography. Corneal tomography means mapping of entire corneal surface. So you know the curvature of the cornea, not only the anterior as well as the posterior surface. Okay? Then specular microscopy. Specular microscopy means when you are doing study of endothelial cells, count and morphology. So that investigation is called specular microscopy. Okay, beta? Now, after this, let's come to the corneal ulcers, the different type of the corneal ulcers. What are the causative agents? What are the symptoms? And what are the peculiar features of the corneal ulcers? That is what you should know it. Now here, first of all, we are going to revise bacterial corneal ulcer. Okay? Because corneal ulcers, they can be caused by infective organisms. There can be non-infective corneal ulcers also. So first of all, we are going to remember about the bacterial corneal ulcers. Now, in corneal ulcers, most of the time there is some risk factor which leads to the infection of the cornea. Now, in corneal ulcers, the trauma, especially in countries like India, some major mechanical trauma is the most important risk factor. Whereas in developed countries, the use of the contact lenses. Now, contact lenses, they also cause kind of micro trauma to the cornea. Okay, but when we call trauma means something, hitting the eye from outside, that is more common in developing countries. Whereas the contact lens use becomes a major risk factor for developed countries. Okay? Now, a corneal ulcer patient will present with certain symptoms, which includes photophobia, redness, pain. Okay, so a painful red eye with decreased vision. Okay, a painful red eye with decreased vision and discharge will be the symptoms in a patient of corneal ulcer. In bacterial corneal ulcers, staph and pneumococcus are the most common causative organisms. Okay, so these are the most common causative organisms. Again, pneumococcus and staph, which one to choose, beta? This becomes again a kind of like MCQ problem, because the studies, they keep coming. Okay, so some studies will say that pneumococcus was found as the most causative organism. Some studies will say staph has been found. And as I told you, most of the time nowadays, we are not getting a question like this, that which organism, at least from the clinical subjects, is the most common organism. The clinical presentation of the condition and how to identify, how to manage is the more important aspect. Okay, so I will advise you to spend less energy on the things ki staph sahi answer hai, ki pneumococcus sahi answer hai. That part as an ophthalmology question is less likely to be asked. The more likely to be asked is what will be the features, what will be the sign, or in case what will be the treatment. Okay, so that's a kind of a general suggestion that where to put in your energy. Put in your energy into more into the clinical aspect of the condition. Okay, right? So both staph and pneumococcus are the common cause of or causative organism for the bacterial corneal ulcer. Now, this part is more important, that what are the features of the bacterial corneal ulcer, or how you will identify that this is a case of corneal ulcer. Now, the eye will show congestion, which is the ciliary congestion. You can see it's red. There will be presence of exudates in the cornea. Okay, so you can see what we call as infiltrate. So these are the exudates and infiltrates. Then there will be ulcer. Ulcer means the epithelium is abraded. And as you can see, the ulcer has a definite boundary. So we call it as well-defined margins of the ulcer. Okay? There can be presence of hypopyon, as you see here. So these are the signs which you will see in bacterial corneal ulcers. The ulcer margins will be defined. There will be what the infiltrate, which you see, it appears wet because it's moist. The hypopyon will be present, which does not contain bacteria, so that is why it is called sterile, and it moves, it is not fixed. Bacterial corneal ulcers, they are associated with early vascularization of the cornea, and the risk of perforation is high. The risk of perforation is high, and perforation is most commonly or seen with pseudomonas infection. So when the bacterial corneal ulcer is due to pseudomonas, the risk of perforation is very, very high, very, very high. Okay, right? So corneal perforation is a complication of the corneal ulcer, and this risk is more when the infection is due to pseudomonas. Then when the corneal ulcer heals, it will leave different kind of the sequelae. It can leave different kind of the opacities. So the corneal opacities which occur after healing of the corneal ulcer, they can be divided into different types depending upon how much thickness of the cornea is involved. So as you see here, the first type, which is a superficial opacity, this is called nebular corneal opacity. Now in nebular corneal opacity, less than 1/3 of corneal thickness is involved. The rest of the cornea is transparent. The superficial 1/3 is opacified. The second type is called macular corneal opacity, in which more than 1/3 but less than half of the corneal thickness is involved. The third type is called leukomatous corneal opacity, in which more than half of the corneal thickness is affected. And the last one, which is shown here, is a type of corneal opacity in which iris tissue, this is iris tissue, which is adherent to the corneal opacity. So this condition is called as adherent leukoma. This is called as adherent leukoma, when iris tissue is adherent to the leukomatous corneal opacity. So these are the different type of the opacities which can develop after healing of the ulcer. Nebular, macular, leukomatous, and adherent leukoma. Okay. Then another sequelae which you can see after the corneal ulcer is formation of what is called as anterior staphyloma. It is usually a sequelae of perforated corneal ulcer. When there is a large ulcer and when it perforates, that leads to the formation of, or in the end, it results in the formation of anterior staphyloma. So what is seen here is, because when the ulcer is very large, the whole of the corneal tissue just kind of melts away and it is replaced by the exudates in the cornea. The healthy tissue doesn't remain, it's all exudates. Now when those exudates, they get organized, means they get fibrosed, and there is also incarceration of the iris tissue that leads to pseudocornea formation. And because this is not a healthy cornea, it bulges, it doesn't have the strength, so it bulges out like this. You can see how bulging it is. So that is what is called as anterior staphyloma. Okay, so it is called as a bulging or ectatic pseudocornea. The bulging is called as ectatic pseudocornea with iris incarceration. So that is what is actually happening. Now this can be asked as an image question, beta. So how to identify if you see that there is a corneal opacity and that cornea is bulging out? That is where you will identify anterior staphyloma. And of course, there will be some description in the saying in which cases the cornea ulcer is more likely to become complicated when, especially somebody is immunosuppressed or somebody is malnourished. Then the healing is not occurring in a normal way. The things are more likely to go into direction of some complication. So there will be a history of malnourishment, immunosuppression, and this picture. So it means there was a corneal ulcer which became complicated. It resulted into a sequelae of complication in the form of anterior staphyloma. Okay? So beta, we have to, when we are in the exam, we have to be smart to identify from whatever clue is there in the case statement, if there is a clinical case, and then try to correlate it with the image. Okay? There will be very few questions which will be just the image. There will be a case statement which will give you a hint about what they want to ask in the image. Okay? Even in your test and discussion questions, you will find many questions relate like this. And in the exam also, you get many questions like this. there will be some key point given in the case statement which will help you to identify the image. ठीक है, because some of you become anxious कि ये image समझ नहीं आ रही है, सारी images एक जैसी लग रही हैं, वो एक जैसी नहीं है बेटा. Each case has few key points in the history, in the signs, in the symptoms, which of course you need to correlate with the image and pick that up. Okay, right? So this is anterior staphylometer beta. Then coming to the fungal corneal ulcers. We just discussed bacterial corneal ulcer, and now fungal corneal ulcers, because fungi are another very common cause of corneal ulcer, and they also present with very typical appearance of the ulcer. The ulcer-based questions will be telling you, you have to remember what is the typical appearance of that ulcer, because that helps in identifying them, that which ulcer the examiner is asking. Okay? Now, in fungal corneal ulcer, the ulcer can be caused by filamentous fungi, which are more commonly seen. Which two filamentous fungi are commonly seen? One is Fusarium, the second is Aspergillus. Candida infection is more commonly seen in immunocompromised diabetic patients. The Candida, which is the yeast, is more common rather than the filamentous fungi. Then risk factor for fungal corneal ulcer is very, very classic, which is trauma to the eye with organic or vegetative matter. Now, these few words are very important to remember, beta. When a person gets eye trauma with some vegetative matter, for example, some tree twig, by leaf, people who are working in the farmers, the gardeners, so they are the ones which are getting hit by organic or vegetative trauma. So if that is the profile in the case scenario, think of fungal corneal ulcer. Okay, think of fungal corneal ulcer. And then fungal corneal ulcer, as we have discussed in our classes also, they have got a very typical appearance of the corneal ulcer, which in contrast to the bacterial ulcer, we see the infiltrates are raised and they are more dry looking. Okay, so it's called as dry raised infiltrate. The margins of the ulcer here are ill-defined. You cannot make a sharp boundary of the margins. And then they have got a main ulcer, and then they have got satellite lesions. Here the satellite lesions are very, very small, but you can note that there is a main ulcer and then there are satellite lesions. And as you see here, the margins of the ulcer, see here you cannot really define that what are the margins of the ulcer. And look at the hypopyon. Most of the time the hypopyon will be very large, a large hypopyon. So these few characteristic features of the ulcer will help you to identify that this is a fungal ulcer. And when the examiner uses these terms in the case statement, feathery, ill-defined margins of the ulcer, satellite lesions, then you should remember that they are talking about the fungal corneal ulcer. Then another thing to remember, the hypopyon in these cases, it contains the fungal hyphae, so it is non-sterile. But despite these features, the perforation and vascularization is rather uncommon in fungal ulcer as compared to the bacterial ulcer. So both these bacterial and fungal ulcers, they can show you the image. They can put the points, especially for fungal ulcer, satellite lesions, feathery margins, large hypopyon, dry raised infiltrate. Do remember this description data. Okay, right? Okay, then coming to another characteristic presentation of the corneal ulcer, which is very, very typical, very, very typical. Again, it can be asked as an image-based question. And this almost is a spot diagnosis, beta. This almost is a spot diagnosis. That they show you this image and they ask you this question. So I think all of you who see this image once, this image cannot be forgotten. You see this typical appearance of the ulcer, which is dendritic ulcer, like tree branches. Okay, so this is your viral keratitis or dendritic keratitis, which is seen in the cases of herpes simplex keratitis or herpes simplex virus, HSV. Okay, this can be spot diagnosis. And then a very typical feature which is associated with viral keratitis is reduced corneal sensations. Reduced corneal sensations. They are also a feature of herpetic infection of the cornea. Herpetic infection of the cornea. Okay, and I will use this figure to ask you or to remind you guys of then what is the stain which is being used here? What is the vital dye or the stain which is being used here, beta? So that can also be asked. So this is the fluorescent stain. This is the fluorescent dye or the fluorescent staining which is identifying the ulcer here. The fluorescent stain, fluorescent which is an orange colored dye. You stain the cornea with the dye and you examine the eye under cobalt blue light. Okay, so that's why this is a bluish image, because you are examining the eye under cobalt blue light, and then the epithelial lesion will appear green in color, right? So this is fluorescent dye staining and we are seeing it under cobalt blue light, beta. So corneal ulcers or these images, they can be shown to you, and they can ask you to identify the dye which is used. The dye which is being used is fluorescent dye, beta. Fluorescent. Okay, right? Then, besides the dendritic ulcers, there can be different presentations which we see in herpes simplex keratitis. As you know, let's revise them. Now, herpes simplex keratitis, it can start as just dot involvement of the epithelium, what is called as punctate epithelial keratopathy. Then it can lead to the formation of dendritic ulcer, which can aggravate to a geographic ulcer. Now, all these are your epithelial involvements are there in these cases, in epithelial keratopathy or dendritic ulcer or in geographic ulcer. Whereas in some cases, it can involve only the stroma. Okay, for example, in stromal keratitis and disciform keratitis. And sometimes when the infection heals, the ulcer remains, what is called as metaherpetic keratitis, which is a neurotrophic type of ulcer. Neurotrophic type of the ulcer. So here there is no active infection. There is no active infection, but since the corneal sensations are reduced, so they also impact the healing of the ulcer. So the ulcer is not going, it's no longer infected, but the ulcer is not going. So these are the different type of the presentations which we can see in herpes simplex keratitis. Okay, showing you the images. Once again, if you see this image, this part here is showing you the dendritic ulcer. And this part here is showing you a geographic ulcer, beta. Geographic means just like a map, you can see, or it's also called as amoeboid ulcer, geographic ulcer or amoeboid ulcer. And then it can be only stromal involvement. It can be only stromal involvement, which is called as disciform keratitis. Disciform keratitis. Now here you see there is no epithelial involvement. It is autoimmune in nature. It is not infective. It is not infective. The number one, dendritic ulcer and geographic ulcer, are the active infective stages, whereas disciform keratitis is autoimmune, right? So in herpes simplex, we can have different type of the presentations, as you see here, and you should remember that. Remember the image-based question of dendritic ulcer, and do remember that this is a type of infection where corneal sensations are reduced. Okay, beta, right? Then another virus which can cause keratitis is your herpes zoster. Now, herpes zoster, again, corneal sensations will be reduced, but zoster infection is common not in healthy people, only in immunocompromised patients. So more common in elderly people, immunocompromised patients. In this case, the things which you should remember, which are high yield, is one is that we do not see typical dendritic ulcer in these cases. What we see is what is called as pseudodendritic keratitis. Okay, so they will not be asking you the image, but they can ask you that whether you see dendrites in herpes zoster. No, you do not see dendrites in herpes zoster. These are pseudodendrites. And then you should remember, when you talk about herpes zoster, about the Hutchinson's sign. What is correct, beta? Yes, that's right. Right? So Hutchinson signs means that when in the vesicular eruptive stage of the herpes zoster infection, if the vesicles, they are seen on tip of the nose, there is high chance that the eye is going to be infected. Okay, because this virus travels along the nerves. It tends to go from the involve the nasociliary nerve. So when the tip of the nose, which is supplied by the same nerve, that can take the infection to the eye. So that is called as Hutchinson sign. That if a patient develops vesicles on tip of the nose, the eye involvement is highly, highly expected. Okay, right? So do remember these two things about herpes zoster keratitis. Now, moving on to few more typical ulcers here. One is your acanthamoeba keratitis. Acanthamoeba keratitis. Okay, so acanthamoeba keratitis, as partly we have discussed already one or more than one time here. This is a keratitis which occurs more commonly with the contact lens use, especially when there is poor hygiene. Cleaning your lenses with contaminated water, sharing of the contact lenses. So that is very important. So these are the risk factors which they can mention in the clinical case scenario. That a person who uses contact lenses but shares it with others, or is not cleaning them with the proper solution, cleaning them with contaminated water. So this will be in the case history. Then acanthamoeba keratitis, in the symptoms, very typical, it is highly painful ulcer. The patient will be experiencing, besides the other symptoms, extreme pain. And then the shape of the ulcer is very, very typical, as you see here. A ring-shaped ulcer. So if the question or in the history they say a patient is showing this image of ring-shaped ulcer with the history of contact lens use with poor hygiene, your diagnosis should be, you can identify this as acanthamoeba keratitis or acanthamoeba ulcer. Okay. So as I told you, do remember the key features, key points in the signs and in the symptoms to identify or to give a correct diagnosis. Okay, right? Then besides the infection, as I told you, there can be other the non-infective ulcers also. In non-infective, the one which you should remember is your Murren's ulcer. Okay, another name for Murren's ulcer is rodent ulcer. So when we talk it as that it is not infective, it means it is due to some autoimmune pathology. It is due to some autoimmune pathology. So for example, in these cases, the pathology is involving the peripheral part of the cornea initially. So it starts as a peripheral ulceration. So how you will identify the Murren's ulcer? It starts as a peripheral ulceration, as you see here. And then another feature which is very classical here is thinning. There is a lot of corneal thinning which we see. So that is why it is called as rodent ulcer. You know, rodents, they burrow the ground. So it's kind of burrowing through the cornea. So a peripheral ulcer with a lot of thinning. So that is indicative of that it is a Murren's ulcer, which is a type of peripheral ulcerative keratitis. Peripheral ulcerative keratitis. Okay, right? Now, few things which you should remember about the treatment of the keratitis. But again, I've taken the points which sometimes are very confusing for you. See, in all kind of infective corneal ulcer, whether it is viral, whether it is fungal, whether it is bacterial, steroids are contraindicated because steroids will interfere with the healing. They will aggravate the infection. So in infective corneal ulcers, steroids are contraindicated. Okay, so you will give antibacterial, antifungal, or antiviral, but no steroids. And you will also be giving cycloplegics in all infective corneal ulcer. Besides the antimicrobial agent, you will be giving cycloplegic, for example, atropine, because that relieves the pain in the ulcer and it also helps in controlling the inflammation. Okay, so that's a general thing. No steroids for any infective corneal ulcer. Okay? And just remember, the only time when you are using the steroids in corneal ulcer when it is due to autoimmune, when the keratitis is due to autoimmune pathology. Okay, so in autoimmune keratitis, steroids are used. Okay, so examples of autoimmune keratitis, for example, disciform keratitis, which is due to herpetic but autoimmune reaction to herpetic. Similarly, in Murren's ulcer, because that is autoimmune, there you will give steroids. Okay, so again, sometimes there is a lot of confusion. Bacterial mein dena hai, fungal mein dena hai. No infective corneal ulcer, steroids are given. They are contraindicated in all infective corneal ulcers. Fine. Okay, then two more type of keratitis which we should revise. One is your neuroparalytic keratitis and neurotrophic keratitis. So again, sometimes that's a confusing point between these two. What is neuroparalytic? What is neurotrophic? Now, neuroparalytic keratitis occurs, this occurs due to seventh nerve palsy. That is facial nerve palsy. So facial nerves supplies orbicularis oculi muscle, which helps in the closure of the eyelids. Beta, they are not going to ask you about the picture of disciform keratitis. There will be always some hint in the question statement. है ना, ऑयल ड्रॉपलेट कैटरेक्ट जहां पूछेंगे वहां गैलेक्टोसीमिया का हिस्ट्री होगा ही होगा डॉक्टर राजपूत. दे विल बी समथिंग इन द केस स्टेटमेंट टू टेल यू अबाउट गैलेक्टोसीमिया. है ना, हम सिर्फ फोटो देख के तो इवन ऑप्थेल्मोलॉजिस्ट भी नहीं बता सकता है बहुत बार, जब तक आप एक्चुअल पेशेंट नहीं देखते हो, जब तक आप कुछ हिस्ट्री, कुछ और पॉइंट्स नहीं पूछते हो. तो एग्जामिनर्स दे कैन नॉट बी दैट क्रूअल most of the time. So there will be something in the case history or in the case statement which will be related to galactosemia. If it is related to galactosemia, oil droplet cataract. If it is related to herpetic infection, or for example, corneal sensations reduced, they will be reduced in keratitis, not in cataract. So we have to correlate. Okay, usually इतनी कहानी हम बोलते हैं या पढ़ते हैं, that has to be correlated with the image. As I told you, spot diagnosis बहुत कम होंगे. So far मैंने सिर्फ 2-4 पे आपको बोला होगा कि this will come as a spot diagnosis image. For example, pterygium, for example, dendritic ulcer. उसको तो किसी और के साथ कंफ्यूज नहीं करेंगे, है ना. बाकियों में जहां पे सिमिलर लुकिंग पिक्चर होता है, the case statement will have something. That's what I'm saying. Beta, remember the key points in the history of that condition, which will help you to make the diagnosis. Fine, right. So neuroparalytic keratitis is due to seventh nerve palsy. Seventh nerve supplies the orbicularis oculi muscle. Orbicularis oculi muscle is responsible for the closure of the eyelid. So when there is facial nerve palsy, the eyelid is not closing properly. And this is called as lag ophthalmos. This is called as lag ophthalmos. Now, when this is occurring, there can be exposure of the lower part of the cornea, which will lead to ulceration. And this type of ulcer is called as neuroparalytic ulcer. Okay, so when it is due to seventh nerve palsy, then exposure of the cornea leads to neuroparalytic keratitis. Whereas neurotrophic ulcer or neurotrophic keratitis occurs when there are reduced corneal sensations. So here the cause is reduced corneal sensations, and reduced corneal sensations can occur due to multiple reasons. For example, fifth nerve palsy, trigeminal, that is the nerve responsible for corneal sensation. Then herpetic infection. Then in diabetic people, in leprosy, these are the condition in which nerves palsies they occur. Okay. Similarly, any condition, for example, stroke, which can be in the area where the fifth nerve nucleus is there. So whenever there are reduced corneal sensation, the cornea is at risk of developing ulceration, which is called neurotrophic keratitis. Okay, so again, these two terms can be confusing. Don't get confused. Neuroparalytic keratitis is when it is due to seventh nerve palsy, and neurotrophic keratitis is when it is due to reduced corneal sensations. When it is due to reduced corneal sensations. Okay, right? Okay, then moving to here, there will be few questions which can be asked as the spot diagnosis or direct image beta. Okay, so please have a look here. So they can show you this image. So in this image, when they show you a side image of the cornea, so there will be something they want you to identify. That is, you have to look at the corneal curvature. So if you look at this image carefully, you can make out that this cornea is conical. Right? Similarly, if they show you this image, you see the cornea is conical. And here in this, when the patient is looking down, the lower lid is also becoming conical. So these two can be easily identified even when there is no history given that this is case of conical cornea, means keratoconus. Isn't it? And the sign which they are showing here is the conical cornea, making the lid also appearing V-shaped. The sign which they are showing here is Munson's sign. Okay, so few things which are very, very typical can be asked as a spot diagnosis. Otherwise, there will always be some history in the case statement. Okay, so here what we are looking at as a condition in which cornea becomes conical due to stromal thinning, which is called keratoconus. So these two images are helping us identifying the diagnosis of keratoconus. Now in keratoconus, besides the Munson signs, you can see various signs which are occurring due to thinning of the cornea and due to irregular curvature of the cornea. Okay, so please remember these are the signs which you get in keratoconus. What are the signs? One is due to irregular astigmatism. When retinoscopy is performed in these patients, you will see a scissoring reflex, which is called Rizzuti sign. Then when we do distant direct ophthalmoscopy, we see an oil droplet reflex, again due to conical cornea. Now this is not oil droplet cataract, this is a reflex which appears as an oil droplet, and it is on DDO. DDO means distant direct ophthalmoscopy, right? Then when we do placido disc examination in these patients, again due to irregular corneal curvature, those rings, they will appear irregular. We see the Munson sign as we have noted. There will be stromal thinning. Due to thinning, you can see vogue stria in the descemet membrane. And there can be deposition of iron, which is Fleischer ring, in the epithelium, corneal epithelium. So please remember these signs which you see here, beta. Okay, Rizzuti sign, which is scissoring reflex seen on retinoscopy. Oil droplet reflex on distant direct ophthalmoscopy. Munson sign, vogue stria, Fleischer ring. Fleischer ring is an iron deposition ring seen in the corneal epithelium. Okay, right? Then another thing which you should remember in keratoconus is that because the cornea is becoming thin, sometimes in the advanced stages, there is occurrence of what is called as corneal hydrops. Corneal hydrops means there is a rupture of descemet membrane due to which there is hydration of the cornea. Corneal hydrops. And the multiple episodes of corneal hydrops can lead to corneal scar. Okay? So in keratoconus, the patient is having blurred vision due to irregular astigmatism. And then because the cornea is becoming thin and thin, there is always a risk of corneal hydrops, which will lead to corneal scarring. Okay? So besides the clinical signs, especially in the early stages, what will be the investigation of the choice? Okay? So when the signs are not that prominent, what will be the investigation of choice for keratoconus? That is corneal tomography, because that can pick up even the mild cases or even the early cases of keratoconus. Okay, right? Then the treatment of keratoconus. Now, there are various options for the treatment of keratoconus, which are divided based upon how much is the severity of the keratoconus. In mild cases, that is in early cases, we use rigid gas permeable contact lenses. Remember, I told you for irregular astigmatism, we prefer lenses. So rigid or RGP, rigid gas permeable contact lenses, they can be given. However, when it is progressive, then we have to do something to reduce the progression of the disease. In that case, the procedure of collagen cross linking, which is called C3R, is done, which reduces the progression of that. In this case, we apply a riboflavin dye to the corneal surface, and then cornea is exposed to ultraviolet A rays, which helps in modulation of the collagen in the cornea. So it helps in reducing the progression. Okay. Then there can also be intacts. Intacts are the ring implants which you insert within the cornea. Within the cornea. So this is again done in advanced cases when the cornea is becoming very thin and you want to give strength to the cornea. Then you can implant rings. These rings are called in short intacts. And in the patients where there is scarring, you can do keratoplasty. So this is again a very important thing to know, beta. Please remember all the treatment methods used for management of a case of keratoconus. Okay, right? So see here. So this is an image which is showing how collagen cross-linking is being done, C3R procedure. Okay? You are exposing the eye to ultraviolet A rays. Now this can be asked as an image question, beta. This can be asked as an image question. So if you see here, they will show you that this procedure is done in which condition. So this is, you can see there are two semicircular rings which are implanted within the cornea. So these are intacts. These are what we call as intacts. So this is done in, of course, keratoconus. This is done for keratoconus. Then the keratoplasty, that is the transplant of the cornea. So this is an image showing the corneal graft. So that can be also be done. So you should identify, you see multiple sutures you can see all around to keep the graft in place. So this is a case which has received corneal transplant. Okay. So please do remember the question based upon the collagen cross-linking, intacts, they all have been asked in the past, beta. So please do remember about that. Okay, right? Then, as some of you were discussing about different corneal deposits, so besides the Fleischer ring, which I just told you, the cornea can show different kind of deposits in different conditions. And what are those? Now, corneal deposits, let's revise the important ones here. The lipid deposition in the cornea. The lipid deposition in the cornea, when it is due to age-related, that's called as arcus senilis. Arcus senilis. Okay. Now, arcus senilis usually starts in the upper and the lower part, and then it can form a complete ring. When it occurs at a relatively younger age, it is called as arcus juvenalis. In those cases, it is associated with hyperlipidemia, but not in the case of arcus senilis. If it occurs in young people, then you must investigate them for hyperlipidemia. Then we have what is called as BSK, or band-shaped keratopathy. Band-shaped keratopathy. Band-shaped keratopathy is due to calcium deposit in the cornea. There are multiple reasons that which are listed in the workbook. It can occur as a result of chronic uveitis. In the cases whenever there is hypercalcemia as a complication of silicone oil in the eye. So, but please remember, especially when there is uveitis, in juvenile rheumatoid arthritis, the band-shaped keratopathy is seen. Okay, when there is uveitis due to juvenile rheumatoid arthritis, the band-shaped keratopathy due to calcium deposition is very common. Fine. Then iron deposit. So already we have done two iron deposit. The Stocker's line, which you see in pterygium. Then Fleischer ring, which you see in keratoconus. So these are the iron deposits in the cornea. Okay. Then we have vortex keratopathy. Vortex keratopathy is when there are drug deposits in the cornea. So very commonly, at least remember chloroquine, which can cause that, and then an anti-glaucoma, netrasudil. So please remember at least these two. There is a list of more, amiodarone, indomethacin, etc. But please remember chloroquine and netrasudil, which can cause drug deposits in the cornea, which is in the form of vortex keratopathy. Okay, right? Then beta, your Kayser-Fleischer ring, okay, which is the copper deposition in the cornea. The copper deposition in the descemet membrane is called as Kayser-Fleischer ring, which appears as a greenish, yellowish, brownish ring. Okay, so this can be your image question, beta, that they show you this image and they ask you to identify the condition. So there will be a greenish brownish ring in the periphery, and of course there will be some history related to, because Kayser-Fleischer ring is seen in Wilson's disease. So you know, Wilson's disease is a condition in which there is involvement of the liver and basal ganglia. Okay, so Wilson's disease, the other name for Wilson's disease is hepatolenticular disease. है ना, पढ़ लिया बेटा अभी मेडिसिन में ये hepatolenticular disease, Wilson's disease. So there is involvement of the liver. So such patients, they have jaundice. They, because of the basal ganglia symptoms, signs, they can have tremors, they can have ataxia. So those kind of features will be there. And in the eye, you see this copper deposition, which is Kayser-Fleischer ring. Okay. Then this ring is not exclusive for Wilson's disease. So whenever there is excess copper deposition in the eye due to some other reason, for example, even in chalcosis. Chalcosis is a condition which is due to a retained intraocular foreign body. When there is a metallic foreign body which stays in the eye, that can lead to chalcosis. So in those cases also you can see a similar ring. So this is not exclusive. This is not exclusive for Wilson's disease, beta. Okay. And then another thing you should remember is that KF ring is not present in all the patients of Wilson's disease. Not every patient of Wilson's disease will have KF ring. Okay. The 90% of patients with neurological involvement will show the Wilson's the KF ring, whereas only 50% patients with hepatic involvement only will show KF ring. So these are few points. Yeah, we'll take a break, but just after some time. Okay, just bear with me for 10 minutes. So 50% of patients with hepatic involvement will be showing the KF ring. And then when the KF ring is very early, what is the best method? Gonioscopy is the best method, beta. Gonioscopy is the best method for early KF ring. Otherwise, you see it on slit lamp, the normal examination, but early KF ring can be diagnosed by doing the test of gonioscopy. So all these points which I have told you about KF ring, you should remember, and as well as the image beta. Okay, right? Okay, then keratoplasty beta. Few things about keratoplasty, because there was a question based upon this in your last exam also. So keratoplasty is your corneal transplantation, where you are taking the host cornea from the cadaver and then you are implanting it into the eye which has diseased cornea. You are removing the diseased cornea of the host and you are replacing it by a donor graft. Okay? In keratoplasty, let's revise the methods of corneal preservation, because when you are taking the donor eyeball or the donor graft, how to preserve that tissue. So this can be a short-term storage. For short-term storage, two methods are used, beta. First one is your moist chamber method, in which you can store. This is used when you have enucleated, when you have removed whole eyeball or globe from the donor. So then you can store it into a moist chamber, keeping it at 4 degrees centigrade. But this is a very short-term storage, only up to 24 hours. Then we have MK medium, which stands for Macquarie-Kaufman medium. This was the question which was asked. Now, this is most commonly used medium where you can store the button, donor corneoscleral button, up to 96 hours. This medium contains tissue culture, dextrane, a buffer, and gentamicin. So we can keep the corneoscleral button into this up to 96 hours. So please remember the name. Okay. Then for intermediate storage, we can use the solutions which contain chondroitin sulfate. They come by the name of Optisol GS or Cornisol, where you can store up to 2 weeks. Okay, they contain chondroitin sulfate. Then very long-term storage can be done with cryopreservation, organ culture, or glycerine. But please remember short-term and intermediate-term storage. Short-term and intermediate-term storage. Make a medium for 96 hours, which is most commonly used medium. Okay, so please remember these methods. Please revise them. Keep in your mind moist chamber, eyeball up to 24 hours, McCarrick-Kaufman medium corneoscleral button up to 96 hours, and then intermediate storage with Optisol or cortisol. Okay, beta? So I'll give you some break, but just few points, because in sclera topic, we just need to remember 1 or 2 points only. Okay, so before taking a small break, let's learn about sclera. A few things which you need to remember, just 1 or 2 things. In sclera, you must remember what is the thinnest part of the sclera. The thinnest part of the sclera is just posterior to the insertion of extraocular muscles. And whenever there is trauma, whenever there is trauma, the scleral rupture can occur in this area, where it is thinnest, obviously, which is just posterior to the insertion of extraocular muscles. Then the inflammation of sclera, that is scleritis, most commonly it is associated with, as I have already told you many times, that whenever you think of scleritis, think of rheumatoid arthritis. So rheumatoid arthritis is the commonest cause of scleritis. Okay, beta, once again, whenever you think of scleritis, think of rheumatoid arthritis. So these two should be together in your mind. Then in patients who have long-standing rheumatoid arthritis, that is having been treated for rheumatoid arthritis for 10 years, 15 years, they show a very typical type of scleritis in which the sclera is becoming thin. You see, the sclera is becoming thin so that the underlying uveal tissue is shining. So this type of the scleritis is called scleromalacia perforans. Now this can be asked as an image question, beta. Scleromalacia perforans, where sclera is becoming thin. It's a necrotizing type of scleritis. And this is seen in long-standing cases of rheumatoid arthritis. Okay, so again, scleromalacia perforans, they can show you this image that a patient having rheumatoid arthritis for so many years presents with this picture. What is your diagnosis? Your diagnosis is scleromalacia perforans. Okay. Then when it is posterior scleritis, please remember 2 key features of posterior scleritis, which is your presence of T sign on ultrasound B scan. And since it is in the posterior part of the sclera, it can also cause exudative retinal detachment. It can also cause exudative retinal detachment. Okay, so scleromalacia perforans in long-standing rheumatoid arthritis. Most common cause of any type of scleritis is rheumatoid arthritis. And posterior scleritis is a condition which is associated with T sign on ultrasound B scan. Okay, right? So we take a short break of 10 minutes, beta, because it's a revision class. Okay, and we have to revise a lot of things. So I'm going to take a short break. Please come back after 10 minutes. We are going to resume in 10 minutes. Right. Okay, friends, let's be back and let's resume our revision. And we are going to revise now the important topics in lens, in the topic of lens, the different type of the cataracts, the management of the cataract surgery, etc. Okay, right? Okay, so in the chapter of the lens, beta, the main thing that you need to remember is that there are different morphological types of the cataracts. So you should know the names of those morphological types. Then you should also know that how different type of the cataracts are seen in different conditions. Most of these can make your one-liner question. Then management of the cataract in terms of cataract surgery is your important topic. Complications of cataract surgery is your important topic. Okay, right? So let's begin. So most of these, they can be asked as your one-liner question, beta. Now let's revise all these high yield points here. So first one is, what is your most common type of congenital cataract? When they ask about most common type of congenital cataract, the answer is blue dot cataract, which is most common. But as we know, this is visually insignificant, that it usually does not cause much problem in the vision. So it's the most common but visually insignificant, blue dot cataract. Okay. Then most common visually significant, that which causes vision problem, that congenital cataract is your lamellar or zonular cataract. Lamellar or zonular cataract is most common visually significant congenital cataract. Then in lamellar or zonular cataract, we see a special feature, what is called as riders. Those opacities, the peripheral opacities which are starting from the center, they are known as riders and which are seen in lamellar or zonular cataract. Okay. Few more important one-liners. Most common type of your acquired cataract. Most common type of your acquired cataract is senile or age-related cataract. Okay. Then in nuclear sclerosis type of the cataract, because of the increase in the refractive index of the eye, there is what is known as index myopia, which leads to second sight of old age. In nuclear sclerosis, there is increase in refractive index of the lens, which leads to index myopia or second sight of the old age. Then we know that in posterior subcapsular cataract, the vision disturbance is experienced by the patient very early, even when the cataract is involving only the small central area. When cataract is involving only the small central area, even then the patient will have vision disturbance or glare. So that is a feature of posterior subcapsular cataract. Whereas in cuneiform cortical cataract, the patient has more problem in dim light when the pupil is dilated, because opacities in the peripheral, in the cortical cataract, they are in the peripheral part. So here the patient has more problem during dim light. And then in early cortical cataract, the patient can experience colored halos. Colored halos are seen in early cortical cataract. Right? So these are few one-liners, one important high-yield points with different cataract. Nuclear sclerosis can cause index myopia or second sight of old age. Posterior subcapsular cataract causes glare and early vision disturbance. Cuneiform cortical cataract causes vision problem in dim light, and colored halos, they can be seen in early cortical cataract. Okay, right? Then in image-based question in cataract, they can show you this image beta, and they tell you that the patient is showing this image. This patient is showing progressive decrease in the vision, but there is increase in the refractive index of the lens. Okay, so here if you see the lens is appearing, as you see, yellowish brown in color. The lens is appearing yellowish brown in color. Now in the image, when the lens is appearing yellowish brown in color, this type of change is seen in nuclear sclerosis cataract. So here you can identify, when the lens is yellowish brown, it is nuclear sclerosis cataract. And why the lens is becoming like this? Because there are changes in the lens protein. And as I was telling you, in these cases, there is increase in refractive index of the lens, especially the nucleus. So that is leading to index myopia. The eye is becoming more myopic due to nuclear sclerosis. And these patients, they have second sight of old age because they are able to read without the reading glasses now, because their index myopia is compensating for the reading glasses. They're able to read without the reading glasses. So nuclear sclerosis, remember the image beta, yellowish brown lens, increase in refractive index of the lens, and second sight of old age. Okay, Bachcha, right? Going ahead. Then again, this can be asked as an image question. This can be asked as an image question. So have a look here. So here you can notice that there is an opacification of the lens, which is in the posterior subcapsular area, which is there in the posterior subcapsular area. So this is posterior subcapsular cataract. Posterior subcapsular cataract. And as I told you, posterior subcapsular cataract causes problem in the vision very early, even though it is only the small part of the lens which is opacified. Another name of posterior subcapsular cataract is also nodal cataract. So please remember this also, because it is present in the nodal area of the lens. This central area is called nodal area of the lens. That's why cataract is also called as nodal cataract. Okay, beta? Right? Then, bache, in cataract, the cataracts, they can cause certain other, besides vision problem, sometimes the cataracts, they can cause some other complications also. For example, glaucoma, that is increase in the eye pressure. Now, the phacomorphic glaucoma can be caused when a mature lens becomes swollen, what is known as intumescent mature cataract. When a mature lens becomes swollen, that causes phacomorphic glaucoma because it is affecting the drainage of the aqueous humor. So phacomorphic glaucoma can be a complication due to intumescent mature cataract. Whereas Morgagnian hypermature cataract can lead to phacolytic glaucoma. Okay? Morgagnian hypermature cataract can lead to phacolytic glaucoma. In sclerotic hypermature cataract, there can be dislocation of the lens. The lens can become dislocated from its place. So these are the different complications which we can sometimes see in advanced cataract. Phacomorphic glaucoma because of intumescent mature cataract. Morgagnian hypermature cataract can lead to phacolytic glaucoma, whereas sclerotic hypermature cataract can be associated with dislocation of the lens. That is, lens is getting displaced from its normal position due to weakness of the zonules. Fine, beta? Then very important one-liners, which can be again there, different type of the cataract seen in different condition. Different type of the cataract seen in different condition. Now, in diabetes, when it is due to uncontrolled blood sugar, the cataract has a very typical appearance, which is called as snowflake cataract. And this is due to accumulation of sorbitol in the lens. Accumulation of sorbitol in the lens that leads to snowflake cataract beta in diabetes. Blunt trauma can lead to rosette type of the cataract. In galactosemia, we see oil droplet cataract. Now, in early stages, this can be reversible because if you control galactosemia by taking the galactose out of the diet, the cataract can reverse also. That's the only type of cataract which can reverse. Then in Wilson's disease, besides KF ring, there can be sunflower cataract you can see. And in myotonic dystrophy, you see Christmas tree cataract. Okay, so different conditions, different morphological types of the cataract. Please remember, they can be asked as your one-liner question. Okay. Then rosette cataract can come as a clinical case question also. This can be asked as a clinical case question also, image-based clinical question. That they tell you that a patient suffered injury with a cricket ball, okay, injury to eye with a cricket ball, and this picture is seen. And this picture is seen. So what is your diagnosis? So can you identify here the typical lens opacity in the form of rosette, like a flower? So when there is a history of blunt trauma and there is a lenticular or lens opacity like this, then you should make a diagnosis of rosette cataract. Rosette cataract. Okay, so that's why I have put it again here. So here your diagnosis is rosette cataract. Please remember, blunt trauma, a flower-shaped cataract, which is seen in case of rosette cataract. Okay, beta? Simple. Have to remember few things, but simple in understanding. Then please remember complicated cataract also. Complicated cataract is the type of cataract which is developing secondary to some other ocular disease. This type of cataract is a posterior subcapsular cataract, as you see here. The type of the cataract is posterior subcapsular, but it has a very typical appearance. It has a polychromatic luster as well as a breadcrumb-like appearance. So these two features are typical of complicated cataract. though it is a posterior subcapsular imposition, but it has a polychromatic luster, as well as the appearance is like breadcrumbs. Okay, beta? And if you remember the causes of complicated cataract, so this can be seen in uveitis. This can be seen in uveitis. What's happening here? In retinitis pigmentosa and in high myopia. Uveitis, retinitis pigmentosa, and in high myopia. So these are the causes of complicated cataract, posterior subcapsular type. Okay, beta? Then few more conditions which can cause a different type of the cataract. In people who work in glass factories, they develop glass blower cataract, in which there is also seen true exfoliation of the lens capsule. True exfoliation of the lens capsule. That's because of the high heat to which the eye is exposed. Similarly, steroids, when they are taken for very long duration, they can lead to drug-induced cataract in the form of posterior subcapsular cataract. Okay? So excessive use and long-term use of steroids can lead to posterior subcapsular type of cataract. Then besides the cataract, please remember a condition called ectopia lentis. Ectopia lentis means that the lens is not in its normal position. There are two important conditions in which we can see ectopia lentis. One is your Marfan syndrome, and second is homocystinuria. In Marfan's, the lens is dislocated superotemporally. In homocystinuria, inferonasally. Even if you don't remember this much, please remember that ectopia lentis can be seen in Marfan syndrome as well as in homocystinuria. Okay. Now coming to the clinical part, beta, related few points related to the management and the surgery of the cataract. Now, we know the cataract surgery can be done by various techniques. We have learned in the class, it can be intracapsular cataract surgery, which is now done only for dislocated lenses. Then we have extracapsular cataract surgery, the conventional extracapsular cataract surgery. We have small incision cataract surgery. We have phacoemulsification. And the latest one is the laser-assisted cataract surgery. Now, the laser which is used in the cataract surgery is your femtosecond laser. Femtosecond laser. Okay. Then when we remove the lens and intraocular implant is done, what is the ideal site of this intraocular implantation? That is in the capsular bag, which is remaining after removing the cataract. So that's the ideal site of intraocular implantation. Then we know that intraocular implants, they come in two types. One is your rigid lenses. The second is your foldable or flexible lenses. The rigid lenses, they are made up of a material called PMMA, polymethyl methaacrylate. Whereas foldable or flexible lenses, the most commonly used or the material is your acrylic lenses. Okay. Then friends, for intraocular lens power calculation, the formula which is used, the standard formula which is used is your SRK2 formula. But important point which you should remember is if a patient is already undergone refractive procedure, for example, LASIK or SMILE previously, in those cases, we cannot use SRK2 formula. Then the formula which are used for the lens power calculation, they are either we will use a Huygens formula or Holliday 2 formula. So these will be giving better and accurate lens power calculation. So these are the few points which are high yield points for your lens implants. Okay. Then identify this image. Identify this image. What is the procedure being done? And identify this image. So if you remember what is being done, see here you can see a lens which is completely white. So it means it was a mature cataract. And then there is, you see this bluish thing. Okay, so this bluish thing is actually the capsule of the lens. The capsule of the lens which has been stained by, this is the capsule of the lens which is stained by a dye. By which dye? Methylene blue dye. Methylene blue dye, or also known as trepan blue dye. Trepan blue, methylene blue or trepan blue dye. This is used to make the capsule prominent so that you can see the capsule when the surgery is being done. And this is the step of capsulotomy which is being performed. This is the step of capsulotomy which is being performed. Okay, so please remember, this can be again asked as the image-based question. And this was a question, I think, in the last year itself, the last exam itself, where they asked to identify the dye. They asked to identify the dye. So this is a methylene blue or a trypan blue dye, which is used to stain the capsule during cataract surgery. Beta. This is one of the steps in the cataract surgery where they are opening and they are making an opening in the capsule of the lens. So procedure of capsulotomy, or also known as capsulorhexis, and the dye which is being used is methylene blue or trypan blue. Fine. Then beta, we have to consider few important points when we are doing the cataract surgery in children. Okay? I'm going to talk about the cataract surgery procedure in the end in the surgical instruments, so don't worry about that. So here are a few things which you should know which are different from the cataract surgery in the adults in children. Now in children, because you know the eyeball is growing, so when you are calculating the lens formula, you have to see that the eyeball will grow in size when the child is growing up. So eyeball when a child is born is hypermetropic, and then when it increases in size, the increase in the axial length leads to myopic shift. Okay, the growth of the eyeball in the children, it leads to change in the axial length. In children, leads to increase in the axial length. So that increase in the axial length leads to a myopic shift. The children, they are born hypermetropic. So when the axial length will increase, there will be a myopic shift. So we have to keep this in mind when we are thinking about the lens power in children. Due to this reason, the lens power is always undercorrected. So we give lesser lens power based upon the formula because these children will be having a myopic shift. And if you want to remember, the undercorrection of 80% is done for less than 2 years of the age. I mean, 80% of the lens power is given, 20% reduction is done. Then 90% of the lens power is given between 2 to 8 years of the age, and 100% that is no change is done for more than 8 years. So that you should remember when we are talking about the lens power calculation in children. Fine? Okay. Then coming to the complications of the cataract surgery, the most common late complication of the cataract surgery, as my friends you know, is the opacification of the posterior capsule of the lens. The posterior capsule on which the lens is implanted, the intraocular lens is implanted, can become opacified with time. This is called as posterior capsular opacification, or also known as after cataract. Now, this can be asked as a clinical case question, that they ask you that a patient who was having good vision after cataract surgery is now having again blurred vision. So what could be the cause? So the most common causes, it can be after cataract. So here you see the lens capsule has become opacified. The treatment of the after cataract is in the form of a laser procedure, which is called capsulotomy, where you make an opening in the center so that the visual axis becomes clear again. And this is called as ND-YAG laser capsulotomy. We use a laser called ND-YAG laser to make an opening in the central capsule. It's called ND-YAG laser capsulotomy. So most common complication, late complication of cataract surgery is posterior capsular opacification. Treatment is ND-YAG laser capsulotomy. Okay, beta, right? Then, what is the most dangerous cataract complication of cataract surgery? The most dangerous is the infection of the inner layers and inner fluids of the eye, which is called as endophthalmitis. That's the most dangerous complication. Now, it can be acute endophthalmitis when it is occurring within 1 week of the surgery, and the most common organism for acute endophthalmitis is Staph epidermidis. Or it can be late endophthalmitis when it can occur after a week to up to even months of the surgery, and in those cases, the causes are Propionibacterium acne and fungi. And what is the treatment of endophthalmitis? We give intravitreal injection of the antibiotics. And if it does not help, then we need to do the pars plana vitrectomy. So this can also be asked as a clinical case scenario, that a patient who had a surgery, the cataract surgery 2 days back, is now presenting with decrease in vision, redness, inflammation. What is your diagnosis? So in those cases, especially for acute endophthalmitis, the diagnosis will be acute endophthalmitis, and the treatment will be intravitreal antibiotics or pars plana vitrectomy. So please remember this too. Okay, so these were the few points which we should know, high yield points from the lens, and we are going to revise the cataract surgery component again at the end of the session. Okay, right? Now coming to the part of the glaucoma, and let's go through the important things which we need to revise about glaucoma. So glaucoma, as we know, is when the pressure in the eye increases. That pressure in the eye increases and it leads to damage to the optic nerve, and that damage to the optic nerve leads to the defects in the visual field. Okay, so remember in glaucoma, so whenever you think of glaucoma, so you have to think of increased intraocular pressure, which is leading to optic nerve changes or optic disc changes. And these optic disc changes, when they are occurring, so that will lead to visual field defects. So that is what is happening in glaucoma, right? Now, some important points in the physiology which you should revise and remember. The aqueous humor in the eye, which is there in the interior segment of the eye, it is produced by ciliary processes of the ciliary body, or this part is also known as pars placaita. Pars placaita. So that is where the aqueous humor is getting produced. The role of the aqueous humor is to provide nutrition to cornea and lens. This aqueous humor has to outflow also out of the anterior segment. So, and there are two pathways for the outflow of the aqueous humor. The major pathway for the outflow is your trabecular meshwork. This meshwork is located in the angle of the anterior chamber. The minor pathway is the uveoscleral pathway. Okay, so aqueous humor is being produced by the pars placaita or the ciliary processes. The outflow is through trabecular meshwork and minimally through the uveoscleral pathway. The normal range of the intraocular pressure is 10 to 21 millimeter of mercury. When the pressure becomes higher than 21 millimeter of mercury, then it can lead to glaucoma, right? So this is the normal range of the intraocular pressure. Now in glaucoma, the measurement of the intraocular pressure is done by a method which is called as tonometry, okay? Which is called as tonometry. Yeah. The measurement of the intraocular pressure is called tonometry. And the instrument which you are seeing here, beta, this can be asked as an image question. Please remember, the instrument which you are seeing here is Goldman applanation tonometer. Okay, so please identify and do remember this prism-like structure which you are seeing. It is your Goldman applanation tonometer, which is the gold standard method for the measurement of intraocular pressure. So this image is Goldman applanation tonometry, and it is the best method or gold standard method for intraocular pressure measurement. So again, all these are your questions. What is the image? Goldman applanation tonometry. What is tonometry? Measurement of intraocular pressure. What is the best method of measurement of intraocular pressure? Goldman applanation tonometry. Okay, right? Then you should be revising the changes which can occur in the optic disc, the different signs which we see as a result of the changes occurring due to glaucomatous optic neuropathy. Okay? So what are these changes and what are the names given to different signs? Let's revise this now. So we know here we are able to see a normal optic disc where the cup size of the cup is within normal range. So this cup is approximately 0.3 in size. You see the neuroretinal rim is healthy. The vessels, they are in normal position. So this is a normal optic disc. But in glaucoma, what we see is there is increase in the cup disc ratio. So the cupping is increasing. There is increase in cup disc ratio. So when gradually the cup is increasing more and more, there is thinning of the neuroretinal rim. You see, the cup is increasing more and there is thinning of the neuroretinal rim. Besides this, there can also be seen hemorrhage, a splinter hemorrhage on the optic disc. We will be seeing nasalization of the vessels. The blood vessels are being pushed towards the nasal side due to enlarging cup. That is called as nasalization of the blood vessels. Now, when these blood vessels are being pushed to one side, they dip into the cup. So that is known as bayoneting of the blood vessels. Bayoneting of the blood vessels. And we also find that these, when cup is increasing, see how the cup has become nearly 0.9. There is very thin rim left behind. We see this laminar dot sign. In the cup, in the large cup, we can see those dot-like areas, what are known as laminar dot sign. So all these are the signs which we see in glaucomatous optic nerve damage. Okay? Increased cupping, splinter hemorrhages, nasalization of the vessels, bayoneting of the vessels, and laminar dot sign. Laminar dot sign. Okay? So please remember this. Then with these optic disc changes, there are also occurring visual field changes, changes in the visual field as a result of glaucoma, which are visual field defects, which are very, very specific of glaucoma. So remember, we learned that when the visual field defects are occurring, they are seen in the germs area of the visual field. The visual field defects of the glaucoma, they appear in what is called as germs area of the visual field. which is central 25 to 30 degree. The first change which occurs is localized constriction of the visual field along with baring of the blind spot. So that is the first change which is occurring in the visual field. Then there is presence of paracentral scotomas. Presence of paracentral scotomas, which you see. Then there can be further progression of the visual field defect, a comma-shaped defect, which is called as sedal scotoma or sedal sun. Then further progression leads to formation of arc-like defect, what is called as Jerem's arcuate scotoma. Then there can be double arcuate scotoma, both superior as well as inferior. It's also called as annular scotoma. These scotomas, they are not exactly same. There is a step formation which is called as Rene's nasal step. That is again peculiar of glaucomatous visual field defect. And in very advanced stages, the patient loses almost all the visual field except a central and a temporal island of the field is remaining. The rest all is lost. Only this is remaining, rest all is lost. So these are the typical glaucomatous field defects which we see in a patient of glaucoma. Okay, revising with me once again, the visual field defects in glaucoma, they are seen in Jerem's area of the visual field. The first one to appear is generalized constriction of the visual field and baring of the blind spot. The second is appearance of paracentral scotomas. Then there is sedal scotoma, which we see. Then there is arcuate scotoma. Then this arcuate scotoma can become double, both upper, inferior, superior, and as well as inferior. Then these two arcuate scotomas are not matching with each other. There is a Rene's nasal step. And then in the last stage, all of the visual field is gone. Only a central area and a temporal island is remaining. Okay, right? So these are very important optic disc changes in glaucoma and what kind of visual field defects which we see in glaucoma. Then coming to a very often asked question in this topic, which is known as buophthalmos or congenital glaucoma. Now this is very, very important and very high yield here. The question can be asked as a clinical case scenario beta and as well as an image-based question. Okay. Now, what will be the clinical case scenario? That a young child, about 5 months, 6 months, 1 year, is brought by the parents with the complaints of blepharospasm, photophobia, and lacrimation. Okay, so these are the three symptoms which the parents they note in the child. So this can be remembered as a mnemonic of BPL. Along with this image. So a child brought by the parents with blepharospasm, photophobia, lacrimation, and with this image in which you see there is a large sized eyeball. See, the size of the eyeball is so big. There is large sized cornea, which is appearing bluish or hazy. So this is a case or typical case, clinical case presentation of buophthalmos or congenital glaucoma beta. Okay, now this is very, very high yield and very important. So besides these features which are visible here, you will see that there is bluish sclera, interior chamber will be deep, eye pressure will be very high, and we see what the folds in the desmate, horizontal folds, which are known as Harb's stria. If you see on slit lamp, you can notice Harb's stria. Okay, and what is the treatment of congenital glaucoma? The treatment is in the form of the surgery. The surgery of the choice when cornea is clear, that is procedure called goniotomy. And in the cases of hazy cornea, the surgery of the choice is trabeculotomy. So again, they can be your question. Goniotomy when there is clear cornea to do the surgery, and the surgery of the choice when there is hazy cornea, trabeculotomy. Fine. So this was the treatment of the congenital glaucoma. Now treatment of or the medical management of the glaucoma is with various anti-glaucoma drugs. And again, questions based upon anti-glaucoma drugs, their mechanism of action and their side effect is very, very important. And let me take you through the few important points here. So in medical therapy, what is the first line anti-glaucoma drug or drug of choice to start the therapy? That is your prostaglandin analogs beta. Prostaglandin analogs. So we have latanoprost, travoprost, lumatoprost, tefloprost. All of these drugs are available and they can be used as the first line drug. Then you should know the mechanism of action and important side effect of these drugs. The mechanism action of prostaglandin analogs is increased uveoscleral outflow. So they increase the uveoscleral outflow and decrease the pressure. And the most common side effect of these drugs is trichomegaly, the eyelashes becoming longer and denser, and dark iris. So that is the common side effect of prostaglandin analogs. And then these drugs, They also increase the inflammation. So they are contraindicated in uveitis and cystoid macular edema. If the eye has uveitis or cystoid macular edema, then we do not use prostaglandin analogs. Right? Other than that, they are the drug of the choice, the first line drugs. Then few important points about the different other anti-glaucoma drugs. Most of them, they can be asked as a one-liner question. So the anti-glaucoma drugs which are contraindicated in a patient of asthma, COPD or heart block, they are your beta blockers because they will worsen these conditions. So beta blockers are contraindicated if the patient has pre-existing asthma, COPD or heart block. Then the drug which is contraindicated in children, that is your brimonidine, because brimonidine can cause sleep apnea in children. Brimonidine can cause sleep apnea in children. So that's why it is contraindicated in children. However, brimonidine is safe to be given in pregnancy. It is safe to be given in pregnancy. Okay. Then drug of choice for acute angle closure glaucoma. Drug of choice for acute angle closure glaucoma, the answer will be pilocarpine because it breaks the attack of angle closure. Whereas drug which is contraindicated in angle closure glaucoma, the answer will be atropine because it dilates the pupil. It is contraindicated in acute angle closure. Then the drug which can cause retinal detachment, that is your pilocarpine. And the drugs which are contraindicated in uveitis with glaucoma, already I told you, prostaglandin analogs, as well as pilocarpine. So these are the few high yield points which you should remember about anti-glaucoma drug, and various anti-glaucoma drugs and their mechanism of action is very, very important. Okay, right? Then something about a newer anti-glaucoma, that is netrasudilbeta. This is a relatively newer drug. Now this drug is a Rho kinase inhibitor group of drug which increases the aqueous outflow through trabecular meshwork. So that is its mechanism of action, that it increases through trabecular meshwork. This drug is very well tolerated, but one side effect which this drug is having, that is the vortex keratopathy. The drug deposits, they can be seen in the cornea. Okay, so netrasudil, please remember, that is one anti-glaucoma drug which can cause vortex keratopathy. Besides this, it's a Rho kinase inhibitor and it increases the aqueous outflow through trabecular meshwork. Okay, beta. These were the drugs. Then what are the laser procedures or the surgical procedures which we can do for glaucoma? Now, the laser which is done for angle closure glaucoma, that is ND-YAG laser iridotomy. Okay. Whereas the laser which is done for open angle glaucoma is laser trabeculoplasty, where you are applying laser to the trabecular meshwork. The surgery for the glaucoma is called trabeculectomy. And we also have valve surgery or drainage implant surgery for glaucoma, which is called as Seton surgery. So Seton surgery is a glaucoma valve or drainage implant surgery. Now a bit about the ND-YAG laser iridotomy. Now ND-YAG laser iridotomy is a procedure in which you are making an opening in the peripheral part of the iris. Okay, you are making an opening in the peripheral part of the iris, as you see here. Now this is being done to create an alternate opening for the flow of the aqueous. So peripheral iridotomy, this image can also be asked. And this is the procedure which is done using ND-YAG laser, and it is done for angle closure glaucoma. Okay, so this should be remembered. ND-YAG laser procedure is done to do iridotomy for the cases of angle closure glaucoma. Okay, fine. So these were the main important things which we need to do about the glaucoma. The different changes which are occurring in glaucoma. Congenital glaucoma, we discussed about the treatment of congenital glaucoma. We discussed about the glaucoma medication and different surgery and the laser procedures which are done in glaucoma. Okay. Now we'll be revising the high yield main topics in the retina, different retina conditions. So here, my dear friends, in retina, starting with some basic things and then going on to the different retinal conditions. So let me just make you revise the different landmarks on the fundus examination, because that will be helpful whenever you are looking at any fundus picture. So you'll be able to identify whether you are looking at a normal fundus or there is some abnormality in the fundus. So please listen carefully. So whenever you see a fundus picture or a fundus image, first of all, always look at the optic disc. Okay, look at the optic disc, that whether the optic disc is normal in color, The margins are well defined. What is the size of the optic cup, whether it is normal or it is more? How are the blood vessels, the retinal vein and the retinal arteries, whether they are normal size or they are tortuous or congested? Okay, so these are the things which you will notice on the optic disc. Then looking at the macular area, so see whether the macular area is normal or not, the central part of the macula, that is fovea, is normal or not. And then of course in the area of the mid periphery. So this is how you will be able to see whether there are any changes like hemorrhages, any deposits, any change in the blood vessels, any change in the appearance of the optic nerve, which will help you to identify whether it is all normal fundus or there are some abnormalities. Okay, right? Then what are the two important investigations which we do in the retinal diseases? So one is the image which you are seeing here. Again, this can be asked as an image question, that identify this investigation. So remember what I have told you in the class, that when there is a fundus picture, but what is black and white, and where blood vessels are appearing white in color. See, blood vessels are appearing white in color. So this is your fundus fluorescent angiography. This is your fundus fluorescent angiography, or in short, it is called FFA. So this is a test which is done to know the vascular diseases of the retina, optic nerve, or choroid. Okay, so this is FFA image. Then identify this investigation. So here what you are seeing is actually the part of the macula. So this investigation, as you remember, is optical coherence tomography. Optical coherence tomography, or also called as OCT, which is done for diseases of the macula. So when we want to know about the different diseases of the macular area, then we do the test of OCT. So you must be able to identify both these investigations, FFA and OCT. Take it up, right? Okay, so then few points about the retinal detachments. What are the important points to remember about retinal detachments? So first of all, you should be remembering the definition of retinal detachment. Separation of the neurosensory retina from RPE, that when the neurosensory retina separates from the retinal pigment epithelium due to accumulation of subretinal fluid, that is called as retinal detachment. Okay? The retinal detachment, when it occurs due to retinal break, that is called as rhegmatogenous retinal detachment. And retinal breaks, they can occur as a result of trauma or due to the degeneration in the retina. And the most common retinal degeneration is lattice degeneration. Okay. What type of the retinal break is most dangerous? The horseshoe tear. And which location of the retinal break is most dangerous? A superotemporal horseshoe tear. That is highly likely to result in rhegmatogenous retinal detachment. Now, how the detachment will appear or how the patient will be presenting. So this can be a clinical case scenario. Now, this is very typical that they show you an image like this. Now, this patient can have floaters, flashes of light, or what is also called as photopsia, and a curtain-like shadow in field of vision. Now, these three things, floaters and flashes of light followed by a curtain-like shadow in the visual field, then your diagnosis is rhegmatogenous retinal detachment. And if you see this image here, you can clearly see there is a horseshoe retinal tear and this retina is detached, right? So this can be your clinical case image-based question beta. So once again, revise with me. If there is signs of flashes, photopsia, curtain-like shadow, so this should make you mark the diagnosis of rhegmatogenous retinal detachment. Then another sign which we see in rhegmatogenous retinal detachment is called as Schaeffer sign or tobacco dusting. That's also a feature of rhegmatogenous retinal detachment. Okay. Whereas what is the most common cause of tractional retinal detachment, in which there is no retinal break, but there is a formation of tractional membranes. So that is seen in the cases of proliferative diabetic retinopathy. Okay. And the third type of retinal detachment is your exudative retinal detachment, which has a typical feature of shifting fluid sign. Okay. So shifting fluid sign is a feature of exudative retinal detachment. And what is the treatment of the retinal detachment? The treatment of the retinal detachment is in the form of surgery. Remember, for rhegmatogenous, we can do pneumatic retinopexy, scleral buckling, pars plana vitrectomy. Whereas for tractional retinal detachment, we do pars plana vitrectomy. For exudative retinal detachment, we treat what is the cause for the retinal detachment. ठीक है बेटा, specifically the clinical case scenario for rheumatogenic RD is very important to know and remember. Now coming to another high yield topic in this section here, which is diabetic retinopathy. That is the changes which you see in the retina due to diabetes. So in diabetic retinopathy, we know it can be your non-proliferative diabetic retinopathy stage. Now, what are the features or the clinical signs which we see in non-proliferative diabetic retinopathy? So number one, friends, one by one. The number one is presence of microaneurysms, which is earliest and hallmark sign of the non-proliferative diabetic retinopathy. The first and the hallmark sign is presence of microaneurysms. Then hard exudates, which are your lipid deposits in the retina. Soft exudates, which are also called as cotton wool spots. And then there will be dot and blot hemorrhages. And no new vessels. In non-proliferative stage, there are no new vessels on the retina. So this is how the fundus image of non-proliferative diabetic retinopathy is seen. Okay, so there will be these dot-like red points, which are your microaneurysms. Then these are the retinal hemorrhages. Okay, the yellow deposits which you are noticing here are your lipid exudates, and this white cotton wool-like area is your soft exudates. And as you see, there are no new blood vessels. No new blood vessels. So that is the stage of non-proliferative diabetic retinopathy. Whereas in proliferative diabetic retinopathy, you will see there is appearance of new vessels on the surface of the retina as well as on the optic disc. So that is the stage of proliferative diabetic retinopathy, when there is neovascularization. So have a look here. This can be again your image-based question. What you notice here, if you see on the fundus, the new blood vessels, a bunch of or a frond of new blood vessels on the optic disc, this is your neovascularization of the disc. Here you are noticing neovascularization elsewhere on the retina. So presence of new vessels in a diabetic patient makes it a stage of proliferative diabetic retinopathy. And we know that in proliferative diabetic retinopathy, the patient can have various complications. And what are the complications which can occur here? If you remember, a patient can develop vitreous hemorrhage. The patient can develop tractional retinal detachment, and patient can develop neovascular glaucoma. Neovascular glaucoma. So these are the complications of the proliferative stage of the diabetic retinopathy. Then in diabetic patients, we also see changes in the macula in the form of diabetic macular edema, when there is presence of hard exudates as well as thickening in the central area of the macula, due to which there is vision loss. So diabetic macular edema is the most common cause of vision loss in diabetic retinopathy. And it can occur in any stage, in non-proliferative as well as in proliferative stage. So that is diabetic macular edema. So you see, you can notice these dense deposits of the lipid in the central area along with the thickening of the retina. So that is diabetic maculopathy. Okay, and these diabetic changes, they are occurring in the retina due to an angiogenic factor, which is called as VEGF. This angiogenic factor is responsible for pathogenesis, and the full form for VEGF is vascular endothelial growth factor. Vascular endothelial growth factor. That is what is VEGF beta. Okay, right? Then, what is the treatment of the diabetic retinopathy? The treatment will depend upon what is the stage. When it is the proliferative stage, then the treatment is pan-retinal photocoagulation laser, which is called as PRP. When it is the diabetic maculopathy, then we do laser in that area, that is focal laser or grid laser. Another option is to go for intravitreal anti-VEGF injections. And when there is a complication of vitreous hemorrhage or tractional retinal detachment, then we have to go with the pars plana vitrectomy. So the treatment will depend upon what are the changes seen. Right? Then in a diabetic patient, there should be a regular examination of the fundus for screening for diabetic retinopathy. And the recommended screening schedule is that for type 1 diabetes mellitus, the screening should start 5 years after the onset of diabetes or after puberty. Whereas for type 2 diabetes mellitus, the screening should start at the same time as the diagnosis of the diabetes. So that is what is the recommendation, that what should be the recommendation for screening schedule of diabetic retinopathy. Okay, friends, right? So diabetic retinopathy, please remember what is non-proliferative, what is proliferative, fundus changes which we see, diabetic maculopathy, VEGF is the angiogenic factor, the complications, what is the treatment, and screening schedule for diabetic retinopathy. Okay, beta? After diabetic retinopathy, let's revise hypertensive retinopathy. So hypertensive retinopathy are the changes which we see in the retina due to increased blood pressure or due to hypertension. Now, this can be depending upon the severity. There is a KW classification or Keith and Wegener classification in which hypertensive retinopathy has been divided into 4 grades. So first one is your grade 1, in which we see that there is mild attenuation, that is narrowing of the arterioles. So hypertensive retinopathy affects the retinal arterioles. So when there is attenuation, only then it is grade 1. In grade 2, there is marked attenuation. There is AV nipping, that the arteries are compressing the veins, and there is what is known as sallucine. Okay. In grade 3, we have grade 2 changes along with presence of flame-shaped hemorrhages, cotton wool spots, hard exudates, as well as bonnet and gun sign. Whereas in grade 4, there are grade 3 changes along with disc edema. So once there is edema of the optic nerve, then it becomes grade 4. So please remember grade 1, grade 2, grade 3, grade 4, sallucine, bonnet sign, and gun sign are the signs which are seen in hypertensive retinopathy. And what is the treatment? That is the control of the blood pressure is the treatment for hypertensive retinopathy. Okay, so please remember what are the changes in different grades here. Right? Okay, guys, moving ahead, and let's now revise few of the vascular diseases which can be there presenting as an fundus images as well as clinical case scenario questions. Beta. Okay, so first one is your central retinal vein occlusion. Now, central retinal vein occlusion, this can be asked as a fundus image, as you see here. And what will be the clinical case scenario? The clinical case will be that a patient presenting with sudden, painless loss of vision. There will be sudden, painless loss of vision with a patient with hypertension or diabetes. And what you see on the fundus, you see multiple retinal hemorrhages in all the 4 quadrants of the retina. So this is called as tomato splash appearance or blood and thunder appearance, multiple retinal hemorrhages. So they will help you in identifying the central retinal vein occlusion. Okay. Then another question which can be asked is, because central retinal vein occlusion also will lead to ischemia, so there can be complication of neovascularization, fractional retinal detachment, as well as neovascular glaucoma. And the neovascular glaucoma, which we see in central retinal vein occlusion, is called 100-day or 90-day glaucoma. Okay, so this is called 100-day or 90-day glaucoma. That is your neovascular glaucoma in central retinal vein occlusion. Okay, right? Then coming to central retinal artery occlusion. Now, in central retinal artery occlusion, again, this can be your clinical case scenario and fundus image. Again, a patient presenting with sudden, painless, marked loss of vision, because in these cases, the vision will be lost to a very severe extent. And what we see, or how do we identify this on the fundus image? So beta, you'll be seeing that there is whole of the retina is appearing whitish or pale due to ischemia, but there is a central cherry red spot. Okay, the pale retina, all the retina is pale due to ischemia, but there is a central cherry red spot. And because of the interrupted blood flow, you will see cattle truck appearance of the blood vessels. Cattle truck appearance, that is because of the emboli. The reason for the artery occlusion is emboli, so they lead to interruption of the blood flow. Okay, so please remember this one again as an image clinical based scenario question is the way mostly the question is asked in central retinal artery occlusion. Okay, beta, right? Then question can also be asked based upon the differential diagnosis of the cherry red spot. So what are the various other conditions where you can see the cherry red spot? So that is your, there is a simple mnemonic here: Christmas tree never grow tall in mud and sand. Okay, so your central retinal artery occlusion, trauma, blunt trauma, Niemann-Pick disease, Gaucher's disease, Tay-Sachs disease, metametic leukodystrophy, and send-off disease. So these are the other conditions where cherry red spot can be there. So please do remember, because the question can be asked based upon this also, that cherry red spot with the features of Tay-Sachs or with the feature of Gaucher, they can ask you that. Okay, so please remember that too. Right? Okay, so now moving to few other conditions in the retina which we should know. So again, the next one is age-related macular degeneration. Age-related macular degeneration, which is of two types. First one is your dry. The second one is called as wet or exudative. The dry is associated with deposits in the macula, which are called as drusels. So as you see here, you see deposits in the macula, yellowish deposits. There are no other vascular changes. So do not confuse them with the lipid exudates. There are no other vascular changes, only yellowish deposits, which are your drusels. So these are the cases of dry age-related macular degeneration. Whereas in wet ARMD or exudative age-related macular degeneration, there will be a formation of choroidal neovascular membrane. Choroidal neovascular membrane, and you will notice that there is hemorrhage, subretinal hemorrhage in the macular area. Now, these macular degenerations, they affect only the macula. Rest of the retina is normal. Only the macula you will notice the changes. So that's a way to identify these. Right? Then, coming to a retinal degeneration, what is known as retinitis pigmentosa. Retinitis pigmentosa. Now, it is a condition in which there is degeneration of rod photoreceptors. Rod photoreceptors. Okay, retinitis pigmentosa, degeneration of rod photoreceptors. And if you remember, the rod photoreceptors are responsible for the vision in dim light or the dark conditions. So these patients will be having symptom of night blindness or nyctalopia. Okay, and then they also have loss of the peripheral field of vision, so they will be suffering from difficulty in driving. And then there is a classical triad, beta. There is a classical triad. This can also be asked as an image-based question. There is pale optic disc, as you see here. The vessels, they have become markedly attenuated, thread-like vessels, and you see these blackish deposits, these black deposits in the mid-peripheral retina. So this is the classical presentation which you are seeing here in retinitis pigmentosa. Okay, classical triad: pale disc, attenuated blood vessels, and bony spicule pigmentation. That's feature of retinitis pigmentosa. And ERG, electroretinogram, is the diagnostic investigation. ERG, electroretinogram, is the diagnostic investigation for retinitis pigmentosa. Now, this can be asked as a clinical case question also. A young boy presenting with night blindness, difficulty in driving, and this is the fundus image. What is your diagnosis? Diagnosis is retinitis pigmentosa. Okay, beta? Right? Okay. Then another retinal condition, that is bull's eye maculopathy. So here, as the name is suggesting, so how you will identify, see, in the macula, there is a pigmentary changes like bull's eye target, a ring of dark and then light and then another dark. So just like a bull's eye target, you can see there is bull's eye maculopathy. Now, bull's eye maculopathy can be seen secondary to chloroquine and hydroxychloroquine toxicity. Chloroquine and hydroxychloroquine toxicity. Okay, so the patients who are on long-term chloroquine and hydroxychloroquine, especially for rheumatoid arthritis like conditions, they can present with bull's eye maculopathy. Okay, beta, please remember this. Okay, so coming to the retinal tumors, coming to the tumors of the posterior segment, and the most important is your retinoblastoma. Most important is your retinoblastoma. Okay, so this is one topic which has been coming repeatedly in all the exams, beta, retinoblastoma. Fine. Okay, so retinoblastoma is the gene which is implicated is your RB1 gene or retinoblastoma, which is located in 13q14 position. The tumor is the most common intraocular tumor of the childhood. It is most common intraocular tumor of the childhood. And the age group of the presentation is usually, the median age group is around 1.5 years. That's the median. Okay. Now, among the tumor, the 40% cases are heritable and 60% cases are non-heritable. And the most common presentation is leukocoria. That is a white papillary reflex. The second most common presentation is presence of strabismus. Okay, so leukocoria or a white papillary reflex is the most common presentation. Second most common presentation is strabismus. Now, what are the differences between heritable and non-heritable retinoblastoma? Now, heritable retinoblastoma occurs due to germline mutation, where the first mutation is in germline cells and the second mutation is in the retinal cells. So here, the tumor will be multifocal and bilateral. And it is just corrected here. And heritable means it will be passed to the offsprings. There will also be increased risk of the secondary tumors, of which osteosarcoma is the most common. These patients, they can also have tumor of the pineal body, which is called pinealoblastoma. So these are the characteristics of heritable retinoblastoma. Whereas non-heritable, both the mutations, they are in the somatic retinal cells. So here the tumor is unifocal, unilateral. It cannot be passed on to the offspring. There is no risk of secondary tumors, and we do not see the pineal body tumor in these cases. So these are the differences between heritable and non-heritable retinoblastoma. Then coming to the presentation, so as I told you, this can be asked as an image-based question as well as a clinical case scenario question, that a child is brought by the parents with the white papillary reflex. And this is the image which you see. You see, here you can see the normal red reflex, but here you see the white papillary reflex, which is due to the tumor in the retina. So that will be your retinoblastoma. And on fundus examination, you see this mass, a cauliflower-like mass. A cauliflower-like mass, and another point which can be entered here with intra or with calcification, cauliflower-like mass with calcification. Now this is very, very characteristic of retinoblastoma, this presentation. A 1-year-old child brought by the parents with white papillary reflex. On examination, this is the image seen. A cauliflower-like mass with calcification is noted on fundus examination. Then your diagnosis is retinoblastoma. Okay, beta, don't miss that. Remember the key points there. Then, on histopathology, if we see these rosette-like patterns, which are called as Flexner-Winter-Steiner rosettes, Flexner-Winter-Steiner rosettes, they are again specific of retinoblastoma. Again, they can be asked as an image question. Okay, that the eyeball was enucleated. On histopathology, Flexner-Winter-Steiner rosettes were found. What is the diagnosis? So Flexner-Winter-Steiner rosettes are specific for retinoblastoma. Okay, bacha, right? Then what are the treatment modalities available for retinoblastoma? So treatment can be done as a focal therapy, which can be done with laser, with cryotherapy, thermotherapy, or brachytherapy. Then chemotherapy is available, and the drugs which are used here, they are your vincristine, etoposide, and carboplatin. So VEC regime is the one which is used. Vincristine, etoposide, carboplatin. Then enucleation along with removal of optic nerve stump is another modality. And then in orbital involvement, radiotherapy is done. Okay, so we have focal therapy, chemotherapy, enucleation, radiotherapy. How to choose? That is based upon the international classification of retinoblastoma. The tumor has been grouped into various groups, group A, B, C, D, E. Okay, now group A is very low risk, B is low risk, C is moderate risk, D is high risk, group E is very high risk. Now, how to choose the treatment? Now, from group A to D, the treatment is focal therapy. You choose the focal therapy. Treatment is to choose focal therapy plus minus chemotherapy. Okay, between group A to D, you choose focal therapy plus minus chemotherapy. Whereas in group E, which is the very high risk advanced tumor, enucleation is the treatment. enucleation is the treatment. Okay, so that's the guideline for treatment. Group E, enucleation. From A to D, focal therapy plus minus chemotherapy. Okay, and the most common spread of the retinoblastoma is through optic nerve. It is through optic nerve. The optic nerve invasion is the most common route for the spread of the tumor. Okay, so these are the points about the retinoblastoma which you should know. And now we move on to the next topic, which is your uveitis beta. Uveitis, which is the inflammation of the uveal layer. And as you know, uveitis can involve your anterior uvea, which is anterior uveitis. It can involve the pars plana and the vitreous, which is intermediate uveitis, or the posterior retina, choroid, and optic nerve, which is your posterior uveitis. Now let's revise important clinical signs which we see in uveitis and the different uveitic conditions which are your high yield points for the exam. Okay, beta, right? Okay, so coming to uveitis, the few clinical signs which you should know and how to identify uveitis based upon a slit lamp image. Okay, so uveitic patient will, what we are talking about is anterior uveitis. Now, the case of anterior uveitis will present with painful red eye with decreased vision. Painful red eye with decreased vision. So that will be the presentation. And what will be the slit lamp findings? So as you can see in this slit lamp image, in the case of anterior uveitis, you will see there is congestion, redness. Okay, you will notice this irregular pupil, which is due to posterior synecdoche, and see this hypopyon. So these are the signs of the inflammation in the interior segment, which will help you making the diagnosis. So there's the diagnosis is of anterior uveitis. The patient presenting with painful red eye with decreased vision. And what are the signs which we will see here? So as I mentioned, there will be congestion. You might notice anterior or aqueous flare and cells on slit lamp examination. Aqueous flare and cells, posterior synecdoche, and hypopyon. So these are the features which are helping in making the diagnosis of anterior uveitis. Besides this, the characteristic signs which you can see is, as you see here, keratotic precipitates. Keratotic precipitates are also called as KPs, which are the deposits on the endothelium, inflammatory deposits on the endothelium. Now these KPs, they can be fine KPs or they can be mutton fat KPs. The fine KPs, they are seen in non-granulomatous inflammation. The mutton fat KPs, they are seen in granulomatous inflammation. Okay. Then another image showing you posterior synecdoche, that is the adhesions between the lens and the iris. Then, besides mutton fat KPs, there are another sign which will be seen in granulomatous uveitis is presence of iris nodules, which can be present in the body of the iris, which is Buska nodule, or at the pupil margin, which are Cope nodules. So iris nodules, they are also feature of granulomatous uveitis, granulomatous anterior uveitis. Okay, so these are the iris nodules seen in granulomatous anterior uveitis. Okay, beta, right? So going once again, aqueous flare and cells, hypopyon, keratotic precipitates, which can be fine or mutton fat, iris nodules, which are seen in granulomatous anterior uveitis. Now, few specific conditions of uveitis which you should remember. Now, there are certain diseases in which we get uveitis as well as arthritis. But the main ones are ankylosing spondylitis, Ritter syndrome, and psoriatic arthritis. Out of these three are associated with HLA-B27 association. They are associated with HLA-B27, right? Now, in juvenile rheumatoid arthritis, it is specifically the pauci-articular seronegative arthritis, which is associated with anterior uveitis. Okay, pauci-articular seronegative type of the JRA is most commonly associated with uveitis. Then let's revise about the toxoplasma. The uveitis which is caused by toxoplasma is your retinochoroiditis. That is the inflammation of the retina as well as choroid. Now, in the active stage, in toxoplasma, we have this headlight in fog appearance. Remember, beta? Headlight in fog appearance, where you see a lesion of retinitis and the whole thing is appearing foggy because of the vitreous inflammation. And when it heals, when the toxoplasma retinochoroiditis healed, then it leaves a punched out scar like this. Punched out scar. So sometimes when there is congenital toxoplasma, the child can be born with a punched out scar in the macula. Toxoplasma. Okay, remember, headlight in fog appearance, and on healing, it can leave punched out scar in the retina. Okay, beta, right? Then, this can be your another image-based question. And what can be the scenario? That there is an HIV positive patient. There is an HIV positive patient with low CD4 counts. Low CD4 counts presenting with this image. So what you're seeing here is actually CMV retinitis. Okay. So in this case, if you see, this typical appearance is called as pizza cheese appearance. Pizza cheese retinitis or pizza cheese appearance, which is feature of CMV retinitis. So there are hemorrhages, there are exudates or the retinitis patches, which are giving it as a pizza cheese appearance. So that's the most common opportunistic infection in HIV positive patient. And what is the drug of the choice? The drug of the choice for here is intravitreal ganciclovir. That will be the drug of the choice for CMV retinitis in HIV positive patient. Intravitreal ganciclovir. Okay, beta, right? Now, coming to another uveitic condition, which is very important and at the same time very interesting, that is sympathetic ophthalmitis. Sympathetic ophthalmitis, beta. Now, what is sympathetic ophthalmitis? It is severe inflammation in the both eyes after injury and very rarely intraocular surgery in one eye. Okay? The most important thing is it should be a penetrating eye trauma, and especially the wounds involving ciliary body are considered to be extremely dangerous. So ciliary body area is called the dangerous area of the eye because when there is penetrating eye trauma involving this area of the eye, the chances or risk of developing uveitis is very, very high. The eye which is injured is your exciting eye and the other eye is called sympathizing eye. And there is bilateral granulomatous panuveitis. The inflammation is in the form of bilateral granulomatous panuveitis. That's again a very important point to remember. Then onset of the inflammation is usually after 2 weeks of the injury. The earliest symptom is weakness of accommodation. So person will have problem in reading. The earliest sign is retrolental flare, inflammation in the interior vitreous. And we also see Dalen-Fuchs nodules in the choroid, the inflammatory nodules in the choroid, which are your Dalen-Fuchs nodules. Now, what is the treatment? In sympathetic ophthalmitis, the treatment is in the form of intensive steroid and immunosuppressants because you have to control the inflammation. That is the treatment of the sympathetic ophthalmitis. So please remember, it will occur only after penetrating eye trauma to the eye. The inflammation is bilateral because one eye is the exciting eye, the other eye is the sympathizing eye. The earliest symptom is weakness of accommodation and the earliest sign is retrolental flare. Okay, beta? So this is sympathetic ophthalmitis. This is sympathetic ophthalmitis. Now going ahead in our revision, now we are moving to neuro-ophthalmology, the topic of neuro-ophthalmology, which will include the diseases involving the optic nerve and the visual pathway and the pupil abnormalities. Again, a very, very important high yield topic for your exam data. Lately, in the last few exams, the questions based upon the pupil abnormality, visual field defects always have been there. So very, very important topic, and you must not miss this one. I mean, doing this one there. Right? Okay, so in neuro-ophthalmology, let's first of all discuss optic neuritis. So optic neuritis means inflammation of the optic nerve. Now, whenever there is optic neuritis, the patient will present with, there will be decreased vision, the patient of optic neuritis will present with decreased vision, defective color vision, Marcus gun pupil or RAPD, and visual field defects. So these are the signs or the symptoms which will occur in the patient of optic neuritis: decreased vision, defective color vision, RAPD, and visual field defects. And the involvement can be in the form of papillitis, when there are changes on the optic nerve in the form of disc hyperemia, blurred visual margins, disc margins, as well as congestion of the vessels, or retrobulbar neuritis, in which fundus exam is normal because it's the part of the optic nerve behind the eyeball which is inflamed. And the third type of the presentation is neuroretinitis, in which there is disc plus macular edema. Okay, so there can be three presentations: papillitis, retrobulbar neuritis, and neuroretinitis. The most common cause of optic neuritis is multiple sclerosis, which is a demyelinating disease. Okay, right? So already I told you what are the signs and symptoms of optic neuritis: decreased vision, then pain on the ocular movements, defective colored vision, Marcus gun pupil. The field defects can be in the form of central or centrocecal scotoma. And in cases of retrobulbar neuritis, you will notice that the patient is having the above symptoms, but fundus examination is normal, as I already told you. So this is how a case of optic neuritis will be presented. This can be there in a clinical case scenario also. Then coming to the second condition, which is your papilledema. Now, what is papilledema? The papilledema is when there is, as you see here, there is bilateral disc edema secondary to increased intracranial pressure. Okay, so whenever there is increase in the intracranial pressure or intracranial tension, there is a passive disc edema of both the eyes because the high pressure is transmitted to the optic nerves. So again, you will see the disc margins, they are blurred. The disc margins are blurred. There is congestion of the vessels, hyperemia of the optic nerve, and even hemorrhages around the disc. So this is what you will be seeing in the cases of papilledema. Now, the various causes of the increased intracranial pressure can be your intracranial space occupying lesions, it can be meningitis, it can be encephalitis, or it can be any condition which is increasing the intracranial pressure. Now, how the patient will be or what are the presentation will be? The patient will be having what is called as amaurosis fugax, that the vision is normal, but there can be transient blurring of the vision. What is amaurosis fugax? Which is transient blurring of the vision. And in the initial time, the pupil reactions will be normal. However, there will be enlarged blind spots on visual fields. So these are the features which will differentiate papilledema from optic neuritis. One is it will be bilateral. Then there is only amaurosis fugax, not decreased vision, no problem with the color vision. Pupil reactions are normal, and the blind spots may be enlarged on the visual field. So that is papilledema. And there is a special type of the papilledema which is called as idiopathic intracranial hypertension. This is also known as pseudotumor cerebri. Now, in this condition, there is no space occupying lesion. Ventricles are normal, but there is idiopathic increase. In intracranial pressure. Okay, so there is normal ventricles on imaging, no space occupying lesion, but idiopathic increase in intracranial pressure, which will lead to papilledema. There are specific risk factors which are there in these cases, which include, it's more common in obese, especially in females, the females who are using oral contraceptive pills, steroids and vitamin A toxicity. Okay, so that is pseudotumor cerebri. The patient presents with frequent episodes of headache. So this can be a clinical case scenario, that a patient who is obese on oral contraceptive pills presents with frequent episodes of headache. There is bilateral disc edema which is seen, but imaging is normal, neuroimaging is normal. Then Most likely it's the case of idiopathic intracranial hypertension will be your differential beta. Okay, so please remember this as a clinical case scenario, this kind of picture, then you can mark the diagnosis of idiopathic intracranial hypertension. Okay, beta. Fine. Now coming to a very important part here in neuro-ophthalmology, which are the different visual field defects. Different visual field defects. So before going through the visual field defects, let me just quickly revise with you different parts of the visual pathway. We know the visual pathway starts in the retina. The nerve fibers from the retina, they make the optic nerve. The optic nerve ends at optic chiasma, where the nasal fibers of the optic nerve, they cross to the opposite side, whereas temporal fibers of the optic nerve, they remain on the same side. So after optic chiasma, we have the optic tract. The optic tract ends at lateral geniculate body, from where the optic radiations, they start. Optic radiations, they pass, some of the optic radiations, they pass through the parietal lobe, some they pass through the temporal lobe. And these radiations, they end in the occipital lobe at the occipital cortex, where you have the visual cortex. Now, lesion at any level of this visual pathway will result in visual field defect. Okay, so one by one, we will be just discussing the different visual field defects and when the lesion is where, and you get the type of the defect. Okay, now when the lesion is in macula, okay, when the lesion is in macula or in the central area, you will get a central scotoma. When the lesion is at the level of the optic nerve, you will get a monoocular vision loss. When the lesion is at the level of optic chiasma, you will get a bitemporal hemianopia, the loss of the visual field on both sides temporally. When the lesion is in the optic tract, we get homonymous hemianopia. Homonymous hemianopia, contralateral. Okay. When the lesion is in temporal lobe, we get a superior quadrantic defect, which is also called pie in the sky. When the lesion is in the parietal lobe, we get inferior quadrantic defect, which is called pie on the sky. Okay, and when the lesion is in the occipital cortex, we again get homonymous hemianopia, but with macula sparing. Homonymous hemianopia with macula sparing. Okay, right? So these are the different visual field defects which we get when the lesions are at a different level, and this we should know, friends. Okay, revising these once more with you. So when the lesion is in the macula, you will get a central scotoma on the same side. When the lesion is in the optic nerve, you will get monoocular vision loss. When the lesion is in the optic chiasma, we get bitemporal hemianopia. When the lesion is in the optic tract, we get contralateral homonymous hemianopia. Like if the lesion is in the left optic tract, the homoanopia will be right-sided homonymous homeanopia. When the lesion is in the temporal lobe, we get superior quadrantic defect. When the lesion is in the parietal lobe, we get inferior quadrantic defect. And when the lesion is again of homonymous homeanopia, but with macula sparing, the central macular area is spared, then the lesion is in the occipital cortex. Fine. Now, as I told you, you must remember that when it is left optic tract involved, supposedly there is left optic tract involved, then this is right, this is left, it will be right-sided homonymous hemianopia. It will be right-sided homonymous hemianopia. So lesion is always on the contralateral side, like this. Okay. Similarly, if it is right temporal lobe, the lesion will be left quadrantic defect, left superior quadrantic defect. Okay, so the lesion is on the field gone is on the opposite side of the lesion. That you should remember. Okay, and then another point which you should remember, especially for the bitemporal hemianopia. So when we are talking about bitemporal hemianopia, it is due to, as I told you, optic chiasma lesion, right? So in this case, the left half of left eye and right half of right eye field is lost. Okay, so this can also be mentioned as like this. Bitemporal hemianopia can also be mentioned like this, that the left half of the left side and the right half of the right eye is lost. Okay, so the question can be asked like this also. You should remember the right half of the right eye, the left half of the left eye. Then what are the lesions which normally cause this kind of problem? They are your pituitary tumors. Your pituitary tumors are the common lesions which cause compression of the central optic chiasma, leading to bitemporal hemianopia. Mostly the pituitary adenoma. So patient can be like, it can be a clinical case scenario that there is a pituitary tumor, the lady presenting with, in cases of adenoma, it can be headache, menstrual irregularities, etc., and a bitemporal field defect or loss of the outer side of the field of in both eyes. So any language can be there. So you have to identify that it is a bitemporal hemianopia. Similarly, craniopharyngioma is another tumor which can cause compression of the central part of the optic chiasma. So this kind of clinical case scenario can be there. Okay? So please remember the site of the lesion and type of the field defect. And as I've told you in a very simplified way, try to remember it like this. Okay? And also try to remember that the field defect will be on the contralateral side. Left optic tract lesion will be causing right-sided homonymous hemianopia. Right temporal lobe will be causing left superior quadrantic defect. Right? So this you should remember, bache. Okay? Right? Okay, now coming to the pupil abnormalities. So what we are seeing here is, see, here both eyes are there. The light is being shown to the right eye. The pupil constricts. But when the light is, both pupils, they constrict. But when the light is switched from the right eye to the left eye, rather than constricting, this pupil is getting dilated. So this paradoxical dilation of the pupil in response to the light is your Marcus gun pupil. This is your Marcus gun pupil, or also called as relative afferent pupillary defect, or RAPD. RAPD. Okay. So what is RAPD? That when the light is brought from the normal side to abnormal side, when the light is shown to the normal eye, both pupils constrict. But when the light is shown to the abnormal side, the pupils, they dilate, because the optic nerve or the retina in the abnormal eye is not healthy. So that is called Marcus gun pupil or relative afferent pupillary defect. And the test which is done to identify this is what is shown in this image. This is called swinging flashlight test. This is called swinging flashlight test. So this can be asked as a question. The swinging flashlight test is done to identify Marcus gun pupil or RAPD. Okay, right? Then what is AR pupil? What is AR pupil or Argyll-Robertson pupil? Now in this case, what happens? The pupil does not react to light. The pupil should constrict when the light source is brought, but it does not react to light. But it reacts to accommodation. So when the near target is shown, pupils, they constrict, but they do not constrict in response to the light. So that is called as AR pupil. It means accommodation reflex is present. Accommodation reflex is present, ARP. So you can remember ARP. Accommodation reflex is present, but light reflex is lost. And this is seen in cases of neurosyphilis. This is seen in cases of neurosyphilis, friends. Argyll-Robertson pupil. Accommodation reflex present, ARP. ARP, Argyll-Robertson pupil. Accommodation reflex is present. The pupils, they constrict in response to a near target, but they do not constrict in response to light. And this is seen in neurosyphilis. Okay, beta? Then the last pupil abnormality which you should know is Horner syndrome. Horner syndrome. Now in Horner syndrome, it is the oculosympathetic paralysis. Oculosympathetic paralysis. So what you notice here is there is mild ptosis due to paralysis of Muller muscle. There is miosis because dilator pupillae is paralyzed. There is anhidrosis, the loss of sweating. And since dilator pupil is paralyzed, there is dilation lag. in the dark. When the patient goes to the dark room, the pupil takes time to dilate, what is called as dilation lag. So this is what is feature of Horner syndrome. It is oculosympathetic paralysis. Okay, so all these features of Horner syndrome are important to remember. It's oculosympathetic paralysis. There is mild ptosis due to paralysis of molar muscle, since dilator pupillae muscle, because it is the dilator pupillae muscle which is paralyzed. So there will be meiosis, pupil becomes smaller in size, and there is a dilation lag in the dark. Okay, so Marcus Gunn pupil, AR pupil, and Horner syndrome, please remember this. Okay? Right, beta? Okay, so next one is the squint to discuss. I'm going to take a small break of 5 minutes, and I will be back with it to finish our topic then. So just taking a break for 5 minutes here, and I'll be back. Time to resume our revision, and we are now going to revise the important points in squint or strabismus. Okay, right? Now in squint, first of all, let's revise the extraocular muscles. The extraocular muscles which move the eyeball in different directions. Now coming to the extraocular muscles, we know that there are 6 extraocular muscles which move the eyeball in different direction. There are 4 recti and 2 obliques. Now coming to the nerve supply of these muscles. The lateral rectus is supplied by the 6th cranial nerve. Superior oblique is supplied by the 4th cranial nerve. And rest all of the muscles, that is medial rectus, inferior rectus, superior rectus, and inferior oblique, they are supplied by 3rd cranial nerve. And this is remembered by this mnemonic, which is LR6, that lateral rectus is supplied by 6th nerve. SO4, superior oblique, is supplied by 4th nerve or the trochlear nerve, and others are supplied by the 3rd nerve. So very easy mnemonic to remember, LR6, SO4, O3. Okay, beta, right? Now, what are the different actions of the extraocular muscles? Now, extraocular muscles, they can have only primary action, or besides that, they can also have secondary action and tertiary action. Now, here, if you see the medial rectus and lateral rectus, they have only primary action. Medial rectus is adductor, moving the eye inwards. Lateral rectus is abductor, moving the eye outward. But superior and inferior rectus and superior and inferior oblique, they have primary, secondary, as well as tertiary action. Now, how to remember the action of these muscles? There are few tips to remember. So they are by a mnemonic SYN RAD. So SYN RAD means all superior muscles, they are in tauters. Means superior rectus as well as superior oblique, they will be in tauters. So it means inferior muscles like inferior rectus and inferior oblique will be causing extorsion. Recti, RA, are adductors. So all recti except lateral rectus, they will cause adduction. So superior rectus, inferior rectus, medial rectus, they will all cause adduction, whereas obliques, that is superior oblique, inferior oblique, they will cause abduction. So with this, that is SYN RAD, you will be able to extract the action of any given intraocular muscle. Action of any given intraocular muscle. For example, if you want me to note down the actions of superior oblique muscle. Okay, so what are the different actions performed by superior oblique muscle? Remember SYN RAD. So superior muscle has to be in tauter. So intorsion. Recti are adductor, it means superior is abductor, abduction. And then oblique muscles, superior will cause depression and inferior will cause elevation, because they are not direct muscles, they are oblique muscles. So intorsion, abduction, and by their name, I will remember that superior oblique is going to cause depression because it's an oblique muscle. So superior one will cause abduction. So see, I'm getting all my actions correct here. Intorsion, depression, abduction. So by remembering SYN RAD and by remembering the fact that recti, the superior rectus will cause elevation, inferior will cause depression. But obliques are obliques. So superior will cause depression and inferior will cause elevation. Okay? So that will help me to know the action performed by any given muscle. Okay? Right? Now, extraocular muscles, they move the eye in different directions, but how they are acting in relation to one another. So what are the synergist muscle? What are the synergist muscle? So synergist muscles are muscles in same eye. Okay, remember, muscles in same eye, that is in one eye, which move the eye in the same direction. Move eye in same direction. So that pair will be synergist muscle. Okay, right? How? Now, superior rectus and inferior oblique, they both move the eye up. So they will be synergist muscle for elevation. Synergist muscle for elevation. Similarly, inferior rectus and superior oblique, they both move the eye downward. So they will be synergist muscle for depression. Okay, so synergist muscle is muscle in the same eye which move the eye in same direction. For example, superior rectus and inferior oblique are synergist for elevation. ठीक है बेटा, बात समझ में आई? उस मूवमेंट के लिए वो सिनर्जिस्ट होंगे. For elevation movement, they are synergist. Similarly, lateral rectus and superior oblique are synergist for abduction. Both are abductors, so they are synergist for abduction. Okay, so they are the muscles in the same eye which move the eye in the same direction. Whereas what are yoke muscles? Yoke muscles are the muscles in the two eyes moving the eyes in the same gaze. Yoke muscles are pair of muscles in two eyes moving them in same gaze. When they are moving them in the same gaze, then they are called yoke muscles. They are one muscle in right eye, one muscle in left eye, which are moving both eyes in the same gaze. For example, when the both eyes, they are in dextro elevation. Okay, so this movement is dextro elevation. The eyes are moving right and up, dextro elevation. So here, right superior rectus and left inferior oblique are yoke muscles. Right superior rectus and left inferior oblique are yoke muscles. Here, right lateral rectus and left medial rectus are yoke muscles. Okay, right? And similarly, here, when the eyes are moving right and down, that is dextro depression. Dextro depression. So right inferior rectus and left superior oblique are yoke muscles. ठीक है बेटा? So yoke muscles are the pair of muscle, one in each eye, which are moving both eyes in the same gaze. Both eyes in the same gaze. Okay. So here, so then the question can be, to identify the yoke muscles. So if they ask you to find yoke muscles for levo elevation. Levo elevation means the eye has to go left and up. The eye has to go left and up. Now, in this case, when the left and up, it has to go, left eye superior rectus will be used. Okay, the rectus of the same side. Left eye superior rectus will be used. And for the other yoke muscle, right inferior oblique will be used. ठीक है बेटा, जिस साइड का अप या डाउन है वहां का रेक्टाई यूज होगा. For levo elevation, left up, left superior rectus will be used, and then you can make out what should be the muscle in the other eye by making opposite of that. Right inferior oblique will be used. Right? Giving you another example. For dextro depression. Dextro depression means right down. The yoke muscles for this gaze, dextro depression, the yoke muscles for this gaze will be right down, means right ka inferior rectus use hoga. Same side rectus muscle, right inferior rectus and left superior oblique. Okay, right inferior rectus and left superior oblique. That will be your yoke muscles. So this is how you will identify the yoke muscle. See which side up and down, and then up the rectus of same side, and then make out the yoke muscle on the other side. The oblique will be for the other side. Okay, beta? That's how you will identify the yoke muscles. Okay, bache. Now coming on to the squint or the strabismus. So in the extraocular muscles, please remember the nerve supply. Please remember what is synergist muscle. Please remember what is yoke muscle and the different actions of the muscles as I have told you. Okay. Now coming to the strabismus or the misalignment or the squint. So what is strabismus, beta? When the two visual axes are not parallel to each other, when they are not aligned to each other, that is called squint or strabismus. It means there is deviation of the one eye. When this squint is latent, that is, it is hidden, it is not manifest, then it is called as phoria. The manifest squint is called as tropia. Now, based upon the deviation, so as you see here in this figure, this eye is showing esotropia, that is inward deviation. Esotropia, inward deviation, or also called as convergent squint. Okay, in this eye is showing as exotropia. Exotropia, that is outward deviation or divergent squint. In this figure, this eye is showing as hypertropia. Hypertropia. And here, this eye is showing as hypotropia, downward, right? Esotropia means inward deviation. Exotropia means outward deviation. Hypertropia means upward deviation. Hypotropia means downward deviation. So that is the name of the different type of the squints. Okay. Then the testing of the squint. The testing of the squint tests, they include Hirschberg test, and cover test and uncover test. Okay. Now Hirschberg test, it will confirm the manifest squint. Cover test again tells us about the manifest squint, and uncover test tells us about the latent squint. Okay. The different tests for the squint, they include Hirschberg test, they will confirm the manifest squint. Cover test, which will confirm the manifest squint, and uncover test, which will confirm the latent squint. So these are the three tests for the squint. Now coming to the paralytic squint. Now paralytic squints are the squints which occur due to the muscle weakness. Okay, so they are the one which occur due to the extraocular muscle weakness, which can be due to muscle problem or due to nerve palsy. Now paralytic squints, they have a feature of diplopia, that is double vision. The movement will be restricted in the direction of the muscle palsy, and a patient will assume compensatory head posture like face turn, head tilt to reduce the diplopia. Okay, so that will be like, head tilt or face turn to reduce diplopia. So these are the common features of paralytic squint. Now, what are the different palsies which you can see? So these can be asked as your question. So please see here carefully. Identify the palsy here. But identify the palsy here. See, look, when the patient is looking straight, this eye is normal, but this eye is showing convergent squint, isn't it? Now, this eye is able to abduct normally. Abduction is normal here. Here, adduction is normal. So here, adduction is normal. Okay. Now, here, again, adduction is normal, but here, abduction is not occurring. This eye is not able to abduct. So, adduction normal, but abduction absent. Abduction is done by which muscle? Lateral rectus muscle. So it means when abduction is absent, it means it is a case of lateral rectus palsy. It is a case of lateral rectus palsy. On which side? Left side. Okay, so see the eye movement and then you can identify which is the palsy here. The adduction is normal, it means medial rectus is normal, but abduction is absent, it means lateral rectus is paralyzed. And because lateral rectus is paralyzed, the eye has gone into convergent squint. So this is a case of lateral rectus or sixth nerve palsy. Okay, right? Now coming to the third nerve palsy. Now third nerve palsy or oculomotor nerve palsy, it can be due to ischemic reason, which are the most common causes, or it can be due to surgical reasons like a trauma at the level of the head trauma, tumors or aneurysms in the brain, which have caused the nerve palsy. Now we know that third nerve supplies all the muscles except for lateral rectus and superior rectus. So all the muscles will be paralyzed and eye will be in a position of down and out, which is the position of lateral rectus and superior oblique, right? Because all muscles other than lateral rectus and superior oblique are paralyzed. So eye will be in down and out position, and there will be diplopia again in all directions in down and out position. And there will also be ptosis due to LPS palsy, levator palpebrae superioris palsy. And the pupil reactions, they can be normal or they can be affected, because third nerve is also carrying the fibers for the pupillary reaction. Okay, beta, what will you be seeing? See, have a look at this image here. Look at the central picture. There is a ptosis there. The eyelid is drooping. And when they are opening the eyelid, the eye is in down and out position. It is down and out position. And if you see, the eye is able to abduct. And it is going slightly to the downward position. But all the rest actions are absent. So it's only the action of lateral rectus and superior oblique, which is intact, and all other actions are paralyzed. So that is your third nerve palsy. When you see that the eye is in down and out position, so this kind of position, down and out position, that indicates that it is a third nerve palsy. Okay, right? Then what will be the features of the fourth nerve palsy? What will be the features of the fourth nerve palsy? The fourth nerve palsy supplies your superior oblique muscle. So it means superior oblique is paralyzed. Superior oblique causes depression of the eye. So there will be hyperdeviation. Eye will be deviated above. There will be head tilt because it's an oblique muscles. There, in adduction movement, there will be limited depression, and there will be diplopia, which is worse on looking down. So the patient has problem in getting down the stairs. So when the patient is looking down and climbing down the stairs, the diplopia will be so much that the patient is having problem. So they are the features of the superior oblique or fourth nerve palsy. The eye will be in hyperdeviation. There will be a head tilt because of the oblique muscle, and there will be a diplopia, which is worse in looking down. Okay, so third nerve palsy, remember the actions, the limitation of abduction. Sixth nerve palsy, remember the action of the lateral rectus. So there will be abduction paralysis. Third nerve, all the muscles are gone except for superior oblique and lateral rectus. So eye is in down and out position. And fourth nerve, because superior oblique is gone, eye will be in hyperdeviation. There will be head tilt, and there will be diplopia, which is worse on looking down. Okay, so that's how you will identify the different muscle palsies. Okay, right? Okay, and then a test which is done to check the stereopsis, that is your Titmus fly test. Okay, a test which is done to check the stereopsis, that whether the stereopsis depth is normal or not. That is your Titmus fly test, where you ask the patient to wear these Polaroid glasses and you check whether the person is able to see the three-dimensional nature of these plates or not. So that is to check whether the stereopsis is present or not, because stereopsis is the indicative of the normal binocular vision. It is indicative of normal binocular vision. Okay, beta, will you remember which is the test for stereopsis? That is Titmus fly test. Right. Then coming to the topic of amblyopia. Now, what is amblyopia? Amblyopia, as we know, is the suppression of the vision in the absence of any organic cause. That eye otherwise is normal, but there is not the normal development of the vision. Suppression of the vision without the organic cause. That is called as amblyopia. And the treatment of the amblyopia is to stimulate the eye which is suppressed, and that is done by doing the occlusion therapy. Okay? So amblyopia is suppression of the vision in one eye or sometimes in both eyes, and the treatment is in the form of occlusion therapy, which is the best treatment for amblyopia, in which we patch the normal eye to stimulate vision in amblyopic eye. Right? Similarly, we can also do penalization. Penalization means where you put atropine in the normal eye, so that vision in that eye will be blurred and a person will use the amblyopic eye. And there can be active vision therapy, that we give active exercises again to stimulate the vision in the amblyopic eye. So amblyopia, when there is suppression of vision during the vision development of phase without any organic cause. And the best therapy for the treatment of amblyopia is occlusion therapy. Occlusion therapy. Okay, right? So here, now moving on to the next topic in our revision session, which is lids and adnexa. That is the diseases of the lids and the adjoining parts of the eyeball. Again, this is a very simple topic, straightforward, but the questions, they have been coming in the lids orbit. The topics which we are going to discuss now are very straightforward topics, okay? Right? So in lids, first of all, you have to remember a few of the conditions which are related to your eyelashes, to lid margins, etc., the different conditions. So what do you see here, bache? What do you see here is the mist-directed eyelashes, which are rubbing at the surface of the eye. So this is your tracheasis. Tracheasis. So tracheasis is misdirected eyelashes. Okay. Then another condition. What do you see here? You see one row of the eyelashes, and then you see another row of the eyelashes. So this is dystachiasis. This is dystachiasis, which is extra row of eyelashes, extra row of eyelashes. Okay, right? Then what is this, friends? Again, you see that there is eyelashes which are in towards the eyeball, but here it is not the eyelashes which are interned. It is the whole lid margin is intact. The whole lid margin is intact. So this is entropion, which is inward turning of lid margin. So this can be asked as a question, image-based question also, that a person is suffering from watering and this is the image. This is inward turning of the lid margin, which is entropion. And as a part for your exam, this thing is better to remember the name of the surgeries used to correct the entropion, because that can be asked in the exam. Beta, I can't really help it. You have to remember the names of these surgeries. They include John's procedures, V's procedure, Quicket procedure, and Wheeler procedure. John, V's, Quicker, Wheeler. So these are the surgeries for the entropion. Right? Then the opposite of entropion is ectropion. When there is, see, have a look here. When there is outward turning or rolling of the lid margin, that is called ectropion. Outward turning of lid margin, that is ectropion. So again, this will lead to watering because the tear film is not able to hold within the eye. So there will be watering. And what are the surgical procedures to correct entropion? Again, please remember the names of the surgery because they can be asked by your examiner here. That includes medial conjunctivoplasty, modified Kunt procedure, VY procedure, lazy T procedure, Z plasty. Okay? So if something like T, VY, Z comes there in the surgery name, think that it is an ectropion surgery, beta. Okay, right? So entropion, ectropion. Then certain lid swellings, and how to identify that, because this can come as an image-based question. Now, if there is a case here in which they say that there is a painless nodular swelling away from lid margin, painless nodule away from lid margin, as you see here, you know that meibomian glands, they are away from the lid margin, and painless means there is no infection. So it means they are talking about clesion. They are talking about clesion, painless nodule away from the lid margin. Okay. Whereas if it is a painful swelling at the lid margin, painful swelling at the lid margin, which is in relation to an eyelash, and there is tenderness, there is erythema, as you see here, then it is your hordoleum externum or stye. Hordoleum externum, or what is also called as stye. Okay, right? So these two case scenarios and these two images, please remember. Painless nodule away from the lid margin, clesion. Painful swelling at the lid margin with tenderness, erythema, hordoleum externum or stye. Okay. Then what is the treatment for clesion? For clesion, there will be incision and curettage. Okay. Whereas for stye, there will be antibiotic and of course the epilation of the cilia to release the pus over there. Okay, beta, right? Okay, then coming to this image here, beta, identify what is the lesion here or what is your diagnosis here. So looking here, if you see this eye, the upper lid is covering the right amount of the cornea, the upper 2 millimeter of the cornea. But if you see here, the upper lid is drooping. It is covering more part of the cornea. So this is drooping of the eyelid. Drooping of the eyelid. And what is the drooping of the eyelid known as? Ptosis. So this is an image of ptosis in the right eye. So left eye is normal. The right eye is showing ptosis. Okay, right, beta? So when this ptosis is associated with certain other signs, we call it as complicated ptosis. But before that, let me make you revise the different surgeries for the ptosis, because this, once the lid is covering more part of the cornea, then it will be affecting the vision. So what are the surgeries done for the ptosis? The surgery done for the ptosis, please again remember the name: the Fastenella Servet procedure, levator resection, and frontalis sling or suspension surgery. So these are the names of the three surgeries done for the ptosis: Fastenella Servet, levator resection, and frontalis sling surgery. Okay, beta, right? Then what I was talking, that when this ptosis is associated with some other problems also, then it is called complicated ptosis. And one of the examples of the complicated ptosis is what is called as Marcus Gunn synkinetic phenomena or Marcus Gunn jaw winking phenomena. in which there is an aberrant connection of the third nerve and the fifth nerve. So what is happening here? If you see this picture once, you'll be able to realize. So here this child is having ptosis. Now when this child opens the jaw, the ptosis also improves. It means with the movement of the jaw muscles, the LPS is also acting because of the aberrant connection between the third and fifth nerve. So fifth nerve is supplying the pterygoid muscles, which are moving your jaw. The third nerve is supplying the LPS. So when there is aberrant connection, the ptosis improves with the swallowing or eating or drinking of any fluids. So that phenomena is called Marcus-Gunn synkinetic phenomena, and this can be asked as a clinical case question. This can be asked as a clinical case question, beta. That a child is there whose ptosis improves on eating or drinking. So what is the diagnosis? Marcus-Gunn synkinetic ptosis. Okay, beta, right? Okay, then another very interesting condition is myasthenia gravis, in which we know there is deficiency of acetylcholine at the neuromuscular junction, due to which there is paralysis of the different muscles. Now, in eye, the myasthenia gravis can affect the LPS muscle as well as the other extraocular muscles. Okay, so first sign, the first and most common eye involvement in myasthenia gravis is in the form of ptosis. Okay, so that is in the form of ptosis, that is drooping of the upper lid. But ptosis in myasthenia gravis has special features that it is asymmetrical, bilateral, and variable throughout the day. Okay, that is, it may be intermittent. It will be less in the morning and more in the evening time, because when the muscle fatigue increases, the ptosis also increases. So it is variable throughout the day. So that is the way to pick up that whether this ptosis is due to myasthenia gravis. It's asymmetrical, bilateral, and variable. And then there are a few tests which help in diagnosis the ptosis due to myasthenia gravis. So one of this is known as ice pack test. That is, when we apply ice packs to the eye, the ptosis improves. See, more ptosis here, and when the ice packs are applied, the ptosis improves. So that indicates that it is due to myasthenia gravis. Similarly, the injection of tensilon, that is tensilon test, or injection of neostigmine, that helps in improving the ptosis. So that helps us in knowing that this ptosis is due to myasthenia gravis. So both on ice pack test and on tensilon test, if the ptosis improves, the chances are that it is due to myasthenia gravis. So again, this can be asked as a clinical question, beta. Okay, right? Okay, then coming to the lacrimal system, the tear film, the drainage, and let's discuss the important points here. Now, in our tear film, friends, there are three components of the tear films, as you know: the lipid component, the aqueous component, and the mucus layer. You should know that from where they are being produced. The lipid layer is the outermost, and it is being produced from the meibomian glands. They are produced from the meibomian glands. Then mucus layer is produced by the goblet cells of the conjunctiva. And then aqueous layer is produced by the lacrimal glands, which include both main lacrimal gland and the accessory lacrimal glands. So this is how the different components of the tear film produced. And a normal healthy tear film is required for the normal visual function of the eye. But when there is deficiency of this tear film, that is known as, condition is known as dry eye. There are different causes of the dry eye, which we have done in detail in the class. How a patient of dry eye will present. So that can be a clinical case scenario. The dry eye patient will present with grittiness, dryness in the eyes, blurred vision. Most often it is common in the people who are using screen for long uninterrupted hours. And how the diagnosis of the dry eye is confirmed? One test is what is known as Schirmer's test, which is shown in this image, which can be asked as an image question also. So here you put a paper, which is a Wattman 41 paper, and you see how much this paper gets wet by the tears. So it helps in measuring, sort of indirect measurement of the tear production. So this is the Schirmer test, which is done for the dry eye. Dry eye. And what is the treatment for the dry eye? The treatment for the dry eye is supplementing the normal tears by giving lubricating drops, and at the same time try to correct the cause of the insufficient tear film, that what depending upon the different as you know, the reasons for the dry eye. So please do remember, Schirmer's test is done for the diagnosis of the dry eye. Okay. Then coming to the nasolacrimal duct obstruction, which will lead to epiphora, that is excessive watering. This nasolacrimal duct obstruction can be congenital or it can be acquired. Now, congenital nasolacrimal duct obstruction is due to failure of canalization of the nasolacrimal duct, and site of obstruction is usually at the valve of Hesner. That normally at birth, by birth, it should have canalized, but when that does not happen, there is obstruction at the lower part, at the level of the valve of Hesner. So this child will be presenting with excessive watering, discharge from the eye, and that needs treatment. The treatment of the congenital NLDO depends upon the age group. Okay, so till 9 months of the age, this protocol is very important to remember. Till 9 months of the age, we will do the massage in the sac area, which is called Krigler's massage. Then if it does not get relief between 9 months to 4 years, we do a procedure of syringing and probing. And if it does not get relieved even after 4 years, then we do a procedure of DCR, dacrocystorhinostomy, in which we make an anastomosis between the lacrimal sac and the middle meatus. The normal opening of the NLDO is inferior meatus. In DCR, the anastomosis is made between lacrimal sac and middle meatus. Okay, so this is a very, very high yield, the protocol for the management of NLDO or nasolacrimal duct obstruction beta. So see in the question, what is the age group, what they are asking, and please answer your question based upon that. Okay, now coming to the important points which we need to revise from the orbit. I'll just be back in a second, beta. Just give me a second here. Okay, so coming to the points which we need to revise in the orbit. Now, as far as the anatomy of the orbit is concerned, please remember that the medial wall is the thinnest and the weakest wall, but the weakest point in the orbit is in the floor of the orbit in the maxillary bone area, and that is where when there is trauma, the floor of the orbit gives away. Okay, right? Then, what is proptosis? Friends, proptosis is the protrusion of the eyeball, abnormal protrusion of the eyeball. Now, this proptosis can be unilateral or bilateral. What are the different causes of the proptosis? The most common cause of unilateral proptosis in children is orbital cellulitis. Now, these questions, they can come up as one-liner. Most common cause of unilateral proptosis in adults is thyroid ophthalmopathy. Most common cause of bilateral proptosis in children is neuroblastoma and leukemia. Okay? Whereas most common cause of bilateral proptosis in adults is thyroid ophthalmopathy. It means for adults, whether it is unilateral or bilateral, commonest cause is thyroid eye disease or thyroid ophthalmopathy. In children, unilateral orbital cellulitis and bilateral neuroblastoma or leukemia. Okay, right? Okay. Then in proptosis can also be intermittent, that it is not present all the time. An example of such kind of proptosis is due to orbital varices, which is the venous malformation in the orbit. In this condition, in orbital varices, the proptosis increases when there is increase in the pressure inside the orbit, for example, coughing, sneezing, or by Valsalva. Okay, so please remember the cause of intermittent proptosis, orbital varices. Then proptosis can also be a pulsatile proptosis when it is due to a kerotico-cavernous fistula or condition like meningocele. Okay, intermittent proptosis, pulsatile proptosis. And now let's learn or revise important points about the thyroid ophthalmopathy. So remember, in thyroid ophthalmopathy, it can involve the lids, the soft tissues in the orbit, extraocular muscles, as well as the optic nerve. So please remember here, what are you seeing in this image, beta? See how marked is the lid retraction. Lid retraction. The lids, which should be upper lids, which should be covering the upper 2 millimeter of the cornea, they are retracted back. So this sign is called as Dalrymple sign. The lid retraction is called as Dalrymple sign. In this case, you can also notice the bilateral proptosis. So first sign in thyroid ophthalmopathy is lid retraction and Dalrymple sign. Similarly, thyroid eye disease can involve the recti muscles, and the most common muscle involved is inferior rectus. Inferior rectus is the most common muscle involved. Just a second, I need to be back in a minute. So we were discussing about the thyroid ophthalmopathy. So as I told you, the first sign is Dalrymple sign or the lid retraction. Most common muscle involved. The first muscle involved in the thyroid eye disease is inferior rectus. And as you know, besides that, there can be optic nerve compression, which is a vision-threatening problem in the cases of the thyroid ophthalmopathy. Then coming to orbital cellulitis beta. Coming to orbital cellulitis. Now, what we call as orbital cellulitis when there is suppurative inflammation of the soft tissues in the orbit. Okay. Now, orbital cellulitis is an ocular emergency. Remember, because the patient presents with there will be kind of like high fever, painful proptosis, restricted eye movements, almost like a frozen globe, that the eye movements are markedly restricted. There will be decreased vision. Okay? So this is how the eye will be appearing. So as you see here, there is proptosis, there is lid swelling, there is erythema, there is conjunctival chemosis, the pupil is dilated, vision will be decreased, the extraocular movements will be markedly restricted. So this is an ocular emergency because not only it is going to involve the optic nerve, it can lead to the intracranial spread of the inflammation and infection. So that is why such kind of a patient needs an urgent hospitalization. The treatment will be the urgent hospitalization and starting of the intravenous antibiotics. And since most of the time the source of infection is the paranasal sinuses, so we have to get an ENC consult also to know the source of the infection and to treat that. Okay, so this can be asked as a clinical case scenario. That a patient coming with fever, painful proptosis, and they show you this picture and they ask you what is the diagnosis. So by the lid edema, by proptosis, dilated pupil, red eye, chemosis, make sure that you're making the right diagnosis of orbital cellulitis beta. Okay, right? So these were the important topics which we need to discuss in the orbit. And now coming to trauma, which lately has been a very favorite topic with the examiners beta. I've seen for the last year and a half, every exam we are getting some question related to the trauma to the eye, be it blunt trauma or injury or foreign body. So there are a few points which you need to know and to revise, and let's go through that. Now in trauma, first of all, let's discuss few important points related to the blunt trauma. So remember, blunt trauma is when the eye is hit by some blunt object and there is just like no full thickness injury or laceration to the eye. That's called blunt trauma. Most of the time the injury is probably in the roadside accidents or somebody hitting the eye with a punch or something like a ball injury, shuttlecock injury. So these can lead to the blunt trauma. Now in blunt trauma, besides various other features, we'll be revising the important ones. So as you see here, what you're noticing here is, see, the pupil is not round. The pupil is what is called as D-shaped pupil. And why it has become D-shaped? Because the iris has got disinserted from its root. Iris has got disinserted from its root. So it is your iridodialysis. It is called iridodialysis, in which there is a D-shaped pupil. D-shaped pupil. Now this does not cause to any remarkable vision problem as such, but a patient can have double image because there are two pupils actually. So this kind of a patient can have diplopia or double vision. Okay, right? And then what do you notice here, beta? What do you notice here? So this patient also underwent blunt trauma, and after trauma, this image was seen. So what is the lesion which you are noting here? So what we are seeing here is actually deposition of the iris pigment in the form of a ring on the lens surface. Okay, and this ring is called Vossius ring. This ring is called Vossius ring, which is again seen in the cases of blunt trauma. Vossius ring. Vossius ring is pigment deposited on the anterior lens surface. Okay? And then as we know that we get rosette cataract. So this can be associated with rosette cataract also, which we have already learned. Okay, so please remember these few characteristic features which can occur: rosette cataract, Vossius ring, iridodialysis due to blunt trauma. Then coming to the orbital blowout fracture. Orbital blowout fracture. Now, orbital blowout fracture is again when there is trauma to the orbit, and most likely site of orbital blowout fracture is the floor of the orbit. Floor of the orbit. So when there is a fracture of the floor of the orbit, the orbital contents, they go into the maxillary antrum. Okay, so what is it's the maxillary sinus which is beneath. So the orbital contents, they go into the maxillary antrum, and this results in this teardrop sign beta. The teardrop sign which we see in the imaging. the teardrop sign, which we see in the imaging here. So that's indication that there is an orbital blowout fracture of the floor of the orbit. Okay, and then besides this, this patient will present with, there will be ecchymosis, there will be diplopia, there will be anesthesia on the cheek because of the entrapment of the infraorbital nerve. So all those features will be there. So this can also be shown as a clinical case scenario, that a patient met with a roadside accident and now it is presenting with periorbital ecchymosis, there is diplopia, and in these cases the patient will have anophthalmos. Anophthalmos means when there is inward protrusion of the not protrusion, inward displacement of the eyeball. So that will also be a feature of orbital floor fracture. So please remember the teardrop signs, the other clinical signs on the orbital blowout fracture, and the most commonly the site is floor of the orbit. Okay, right? Then coming to the injuries with the foreign bodies in the eye. Now, injuries with the foreign bodies in the eye, there can be different kind of the injuries. It can be a superficial foreign body, for example, like this. Now here, if you see, the foreign body is impacted in the superficial part of the cornea. It is impacted in the superficial part of the cornea. So this kind of foreign body, which is in the superficial part of the cornea, that can be removed in the eye OPD itself. Okay, because the patient is having redness, watering, irritation, and he comes to you in the OPD, you can see the superficial foreign body on the slit lamp examination. So these, they can be removed safely in the eye OPD by using a 26 gauge needle. You scrape off this foreign body, give antibiotic to the patient, and the patient will be fine. But sometimes when the injury is like that the foreign body is impacted deep like this, then do not attempt to remove this in the eye OPD. This kind of foreign body, which is a deep foreign body, that should be managed in the operating theater. So never try to pull out this kind of thing, because that can further damage the eye. So never pull out these kind of antibiotics. They should be removed in the operative theater. Then sometimes the foreign bodies, they are hidden within the eyeball and they remain retained. They remain retained within the eye, that either they were missed and were not removed, or patient did not seek the treatment. So these retained intraocular foreign bodies, they, especially when they are the metallic foreign bodies, so when there are retained metallic foreign bodies, then they can slowly release the metallic deposits within the eye structures and they can cause permanent damage. Now, when this kind of foreign body is an iron foreign body, then the iron starts getting slowly deposited in the cornea, lens, iris, retina, and this condition is then known as sidrosis bulbi. The iron gets deposited within the different parts of the eye, and this condition is called sidrosis bulbi. And the retinal deposits, they can lead to permanent retinal degeneration also. And already I discussed with you, when a copper foreign body is retained, it leads to copper deposition, which is called as chalcosis, and it produces the signs similar to Wilson's disease. You will see a KF ring, you will see a sunflower cataract. Okay, so it should be, whenever there is trauma and you suspect that there can be a metallic foreign body, for example, some worker which is working in the factory, then it should be made sure that that metallic foreign body is removed out of the eye. But when you are investigating a metallic foreign body, the investigation which should be avoided is your MRI, because MRI can move the foreign body within the eye and can cause more damage. So when you suspect metallic foreign body, do not do MRI scan. Okay, so avoid MRI scan when you suspect, when a metallic foreign body is suspected. Do CT, you can do the CT scan, but do not do the MRI scan. Okay, so these are the few points related to the trauma. As I told you, trauma has been a favorite question with the examiner. Foreign bodies, how to remove the foreign bodies, trauma related to blunt trauma or orbital floor fracture. So please revise them nicely. Okay, now in the last part, I'm going to summarize for you the examination, important examination techniques, instrument, and few of the surgical procedures, so that it's a quick revision to cover all the high yield points here. Okay. Now in examination technique, I told you for the anterior segment examination, we use an instrument which is called slit lamp. So this is your slit lamp. Now this slit lamp has, as you see here, this is the viewer's side or the examiner side. On this side, the patient places the chin here, and you can view the different parts of the eye by using the lens system which is there inside the slit lamp. Okay. And when we are doing the slit lamp examination of the anterior segment, I have already told you that it makes an optical section of the different parts of the eyeball. So you can see cornea, you can see anterior chamber which is filled with the aqueous, you see iris, through the pupil you can see lens, beyond the lens you can see anterior part of the vitreous. And then you can use a special lens to see the retina also. By using a +90 diopter lens, you can view the posterior segment also. So this is your slit lamp, which is an instrument to examine the eye in a magnified and more detailed way. Okay. Then for your retina or for your posterior segment, we have the instrument available in the form of ophthalmoscope, which is one is your direct ophthalmoscope. Now, direct ophthalmoscope is an instrument like this, beta. Okay, it has an illumination, a battery illumination within itself. This is held in one hand and it helps in the monoocular, that you are using one eye to examine the patient's retina. Okay, so here in this figure, the examiner is examining an eye of the patient. For this, you have to come very close to the patient's eye, as you can see here. Okay, so how you will identify, sorry, that what procedure is being done. That is, you can see the examiner is holding an instrument in the hand and it is coming very close to the patient's eye. Now, direct ophthalmoscope helps us in examining the central retina. It provides a very good magnification, which is 15 times, and it produces an image which is virtual and erect. But of course, the disadvantage is that you are viewing a very small part of the retina, only the central retina at one point of time. Okay. Distant ophthalmoscope can also be used for the procedure of distant direct ophthalmoscopy, or what is called as DDO. I'm sorry. Distant direct ophthalmoscopy. So here the same is eye from a distance around 25 centimeters or so. Now, distant direct ophthalmoscopy, you shine the light from the ophthalmoscope onto the patient's eye. And you want to see that how is the reflex coming from the retina. So you are checking the light reflex from the retina. Right, light reflex from the retina is what you are checking. So normally the light reflex from the retina is red reflex. Normally it is a red reflex which you see from the retina. But if there is any disease, for example, retinal detachment or tumor, for example, retinoblastoma, then you will get a white reflex. Okay, so normally the reflex should be red, but when there is a tumor or a detachment, then you get a leukocoria or a white reflex. So this can be tested by distant direct ophthalmoscopy. Okay, then another instrument which is used to examine the fundus or the posterior segment is your indirect ophthalmoscope. Indirect ophthalmoscope. Okay, so this instrument is your indirect ophthalmoscope. Now this is worn by the examiner on the head, as you see here. Examiner wears this indirect ophthalmoscope on the head, and then there is a special lens which is used. The indirect ophthalmoscope has a light source which goes into the patient's eye, and the lens helps in making an image of the retina for the examiner to see. So this is your indirect ophthalmoscope, beta. Okay, so in this case, you can see central as well as peripheral retina. So that is why whenever you want to check the retinal periphery, for example, in the cases of high myopes, or in the cases of trauma, or in the cases of retinal detachment, where you want to find the retinal break, you will use indirect ophthalmoscope. Indirect ophthalmoscope provides a magnification of 3 to 5 times. We are using both our eyes to examine, so it is giving a very nice binocular stereoscopic view. And the image which is seen by the examiner is a real inverted image. Okay, so these are the characteristics of the when we do the fundus examination using indirect ophthalmoscope, beta. Okay, right? Then few exam techniques quickly revising with you. So as you see, these are the vision charts which are used for the distance vision testing. This is your Snellen's chart for the distance vision testing. These are your Landolt charts, the C charts and the E charts for testing the vision in illiterate people. Okay. Do you identify this chart, beta? Remember, this is your ETDRS chart. ETDRS chart, in which there are 5 letters in each row. Early treatment of diabetic retinopathy study chart, which is again used for testing the vision, but mainly for the research purposes. ETDRS chart. And do you remember this one, bache? These are your color vision testing. This is to test the color vision. These are Ishihara color plates. These are the Ishihara color plates for color vision testing. Okay, bacha? Then few instruments which we need to know. Okay, this is your Clegion clamp, beta. Clegion clamp, and this is the scoop which is done to remove or curate out the material of the Clegion. So Clegion clamp and Clegion scoop. So just to show you how it is done. So clamp is used to engage the Clegion, and then we make an incision here and we curate out the collection which is collected there. Okay, so Clegion clamp and scoop, they are used for incision and curettage of the Clegion. Then lacrimal probes, I have shown you these in the class also. The lacrimal probes, they are used for the syringing and probing. Syringing and probing. So just these are the thin metallic probes of different sizes as you see here. These are the lacrimal probes for syringing and probing. Okay, beta, right? And this is your DCR punch. This is your DCR punch, the instrument to punch out the bone in DCR surgery. Because here we have to make an opening between sac and the middle meatus. So this part of the bone has to be removed. So this part of the bone is removed by using DCR punch. Okay, beta, right? Then this what you are seeing here is what is known as enucleation spoon, beta. Enucleation spoon and scissors. So obviously they are used to do the procedure of enucleation. So here you see this part is there, this U-shaped part. This is to engage the optic nerve. So you hold it like this, you put it tumors, intraocular tumors like retinoblastoma. So there you engage the optic nerve by fixing it in the enucleation spoon, and then you cut it using the enucleation scissor, right? So this is the procedure of the enucleation. Just for your reference, I have put this picture, how the eyeball, even when you are taking the donor eyeball from the cadaveric eye, you have to do the enucleation. So this is how you are doing that. Okay, right? Then there is another procedure which is called as evisceration. So that also you should know. Evisceration is when it is your removal of middle and inner layers of the eyeball. Okay, that procedure is called evisceration. You are leaving out the scleral shell. Okay? So of course you cut the corneal button. You remove the inner layers of the eyeball and you leave the scleral shell. So that procedure is called as evisceration. So evisceration is done for certain conditions when there is infection in the inner layers of the eyeball. We call them as panophthalmitis. So that is where the evisceration is done. This is just basically to show you that there is an enucleation where you're removing whole of the eyeball, and then there is an evisceration when you're removing the middle and the inner layers of the eyeball. Okay. Then beta, in the phacoemulsification, as I told you already about the capsular staining, why the capsule is stained when you want to see the capsule better. The stain which is used is your methylene blue, or it comes by the name of trepan blue. Okay. Then in phacoemulsification, you make an incision, which is a tunnel-like, valve-like incision. You do capsulotomy, which is called as capsulorhexis. You will do a procedure of hydrodissection, where you will separate the lens from the lens capsule. You will use the phaco probe to segment the lens into different pieces, which will be then removed. You remove the cortical matter, and then you implant the new lens. Okay, so you should be aware of the different steps of the cataract surgery. Fine. And when we are using the laser, the femtosecond laser, then we can do the incision, the capsulotomy, and fragmentation of the nucleus using the laser, femtosecond laser. Okay, right? Fine. Then I have summarized in this last slide the different type of the lasers which are used in the ophthalmology in different procedures. Okay, so this is the summary of all the lasers which are used in the ophthalmology. So first of all, ND-YAG laser. Remember, ND-YAG laser is the laser which is used for capsulotomy, which is done for the treatment of after cataract, and iridotomy, which is done for the angle closure glaucoma. Okay, beta. Then excimer laser. Excimer laser is used for refractive procedures of PRK and LASIK. Then femtosecond laser. Femtosecond laser is used in the SMILE procedure, LASIK procedure, as well as laser-assisted cataract surgery. Okay, femtosecond is used for SMILE procedure, LASIK procedure, and laser-assisted cataract surgery. Then frequency doubled ND-YAG laser, beta. Frequency doubled ND-YAG laser, which is used for retinal photocoagulation. Then we also use diode laser for retinal photocoagulation, as well as for thermotherapy. Remember the focal therapy of the tumors, thermotherapy. And argon laser is another laser which is used for the retinal photocoagulation. So we can use frequency double ND-YAG, FDND is different. Frequency double ND-YAG, diode laser, and argon laser for retinal photocoagulation. So this is summary of the different names of the lasers which are used in retina and the procedures for which they are being used. Okay, so with this we are finishing our session of the revision in ophthalmology. I hope this summary will be useful to cover all the high yield points. But as I told in the beginning, beta, this is a revision. I sincerely hope that you guys have, gone through the workbook at least once. This is for when you need, your second revision, your third revision to follow during that time. But please go through the workbook once so that the things are more comprehensive in your preparation budget. Okay, so all the very best. Your subject test is coming very soon, and all the very best, of course, for the final exam. And keep on putting the hard work, beta. There is no substitute for the hard work. I know you guys have too many subjects to do, too many things to do, but this is the time when we are supposed to do this, isn't it? Okay, so be a little bit hard on yourself. As I always say, push yourself, because without the hard work, the success is difficult. I mean, even in your heart, you will know that if you have not put your best, you cannot expect the best. Okay? So try to give your best. Try to go through the subject. Still, there is a time when you go through the subject nicely. Do not think of the shortcuts at this stage. Try to do as much. Whatever you do, try to do it in a good way. Okay, so all the very best, and we'll be in touch. I'm going to see you after your subject test also, and there will be different times